it. I know Professor Senait doesn't want us to talk about her. My sister, I will talk about you. I have to say, if in Africa we had 4 Senait, Africa will change. She was not there in Zambia when I was talking about her. MELP will not be MELP without Senait. CPHIA will not be CPHIA without Senait. She's someone who believes in Africa. I didn't convince, maybe if we build a 3rd building, maybe we'll have Senait. But for now, Professor Senait, let us celebrate you. Let us recognize what you are doing, your passion for Africa. And we are really grateful to have you. Thank you very much. Excellencies, ladies and gentlemen, we have a number of ministers. Some of them, they are coming, others, they are here. While we know that this is a busy time, we had head of state we confirmed, but let us accept also there are so many conflicts during the AU Assembly. We have around 39 ministers who confirmed. And this is huge. This is huge. This is a clear demonstration that we can work together. And this is a clear acceptation of the role of Africa CDC to lead the public health agenda in Africa. We cannot lead this agenda without our leaders who are ministers. We are so grateful to have a number of them here. And we'll take this opportunity to listen and to exchange. We believe that this second high-level annual ministerial forum will give us opportunity to come together, to think about where we want our continent to be in a few years. As leaders, please let us embrace our responsibility of humility and integrity, striving to inspire others, foster collaboration, and leave a lasting legacy of hope, progress, and prosperity for future generations. I thank you.
Thank you, Director General. Across the continent, we face a great many health challenges, but in the wake of the COVID-19 pandemic, African nations are also demonstrating extraordinary leadership and ingenuity in addressing these long-standing and emerging health challenges. I'd like to invite you just for a moment to turn your attention to the screen for a short video that highlights the value of the Ministerial Executive Leadership Program from aspiration to action.
As ministers, what role could we play beyond our national borders? What kind of legacy agendas can we craft that goes beyond our national borders to make sure that our countries are safe and the continent is safe, and we have the capacity to implement these initiatives?
I feel that's a much more equipped with more information because again, we were able to hear various stories of ministers of health, past, by the way, and present. And among the past ministers, we had very good ministers who really spent a lot of years in the health sector and did great works.
This executive leadership program is intended to help ministers really forge partnerships among African ministers, among collaborators, and within their own countries, a cross-governmental and a whole-of-government approach to strengthen and build a resilient and strong health system.
I think if you work on better diagnosing the problem, you know all of the components of what it takes to be able to fix that problem.
This training of ministers has really enriched me from a technical point of view, because one of the things also that I've learned is that there are many coalitions that you can build.
There's the adage or the saying that's been going around, it's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve our own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking with one voice. I think that's the way we should go for a better Africa.
What is it MELP, Ministerial Executive Leadership Program? For me, it's not a training. For me, it's a wonderful opportunity that we have to talk to each other, to exchange. It's a wonderful opportunity that we have to think about Africa. Where are we going? What are we doing? How can we work together? How can we have one voice?
I think bringing all of these people together and sharing a common African brain trust, at the same time having former ministers, former leaders in their own right come and join this group. I think we're co-creatively looking at diagnosing these problems. We're co-creatively looking at solutions for it. And I think we'll walk away from this better informed. We'll work away from this knowing that we will not only be executing and implementing at our country level, but we'll have the resource of the whole continent, all 55 countries, helping us to work this journey.
The conversation today is going to explore some of the transformative and progressive leadership really needed to continue breaking barriers and fostering progress to lead us toward a new public health order for Africa. Distinguished guests, I would like to invite Her Excellency, Dr. Nkosazana Dlamini Zuma, the former chairperson of the African Union Commission, to say a few words. Please give her your warmest welcome.
Thank you very much, Program Director. I'd also like to greet, even though he's just stepped out, Dr. Jean Kassan, the DG of CDC Africa. But let me greet the ministers of health who are here, all the officials, our partners who have worked with us for a long time. I'm not going to talk so much about the contemporary health issues because the ministers of health are there to do that. But I'm just going to pick up on what is there, a whole of government approach. Why do we have a whole of government approach? If we go to our agenda 2063, we say that we need to build a healthy and well-nourished citizens. That's part of Agenda 2063. But ministers of health cannot have healthy citizens alone, because for anyone to be healthy, there are certain health determinants that need to be fulfilled. You need to have clean water, and ministers of health are not the ones that deliver clean water. You need to have energy, clean energy. You need to have clean air. You need to have food, healthy food. You need to have education. We know that mothers who are educated tend to have healthier children. You need people who are not poor. So all these things are not things that can be done by ministers of health. It's the rest of government. That's why I like that, the whole of government approach. People need to live in proper habitats. Housing, it's not the ministers of health who will provide that. There needs to be safety and security for your mental health. It's not the ministers of health who provide that. So indeed, we need a whole of government approach. And even what we are talking about, manufacturing, pharmaceuticals, and so on, we need the ministers of trade and industry and others to support those programs. So it's very important to take that approach, the whole of government approach. Need to have healthy young people who play sports. It's not the ministers of health who do that. And so I would really like to emphasize on that. Of course, ministers have a big role to play. I won't talk about they know it. I had the privilege also of being the first Minister of Health in a democratic South Africa, but that's a long time ago. Things have changed. Things have changed. Some remain the same, but some have changed. And I also want to say, we need to emphasize the primary health care, the prevention. There we say disease control and prevention. If it was according to me, I would say disease prevention and control, because you have less work if you can deal with the prevention. Even during pandemics, if you have a healthy population with strong immune systems, it helps. It helps. It's not the only thing, but it helps. I also want to just talk about Africa and what we can do. Yes, we work with partners, but I was very proud of being an African and of Africans during the Ebola and COVID. During Ebola, when we were at the UN, we were told that 1.4 million Africans are going to die unless something dramatic happens. And I'm glad to say less than 100,000 Africans died. That's too many, but it's not the 1.4 million that was predicted. And that was because Africa came together. Africa came together and decided we're going to deal with this ourselves. The African business came together and provided the funding. We did not wait for funding from elsewhere. We appreciate those who helped, but how that was dealt with was through African solidarity and Pan-Africanism. African countries sent health workers, seconded them there. And I remember one time when we were interviewing and training some of the young people who were going to those countries. One young man from Kenya said, when we said, what motivated you to volunteer? And he said, one, I thought, what if this was happening in Kenya and nobody came? How would we feel? How would we cope? So I decided I must be a volunteer. And he also said, we always talk about Pan-Africanism, but this is one concrete way of showing our Pan-Africanism. And I think we shouldn't underestimate ourselves as Africans. If we work together, a united Africa is a very strong Africa. If we work together, support one another, and take the destiny of Africa in our hands. Yes, we appreciate helping hands, and we allow those who want to help us, but we must take the first step ourselves. Of course, we've learned a lot through these pandemics, even at least during Ebola, CDC was not there. During COVID, it was there, and it played an important role. And so that I don't take too much time, I want to just end by saying I'm really humbled, at the same time honored that there is a wing here named after me. I'm very grateful to both the CDC, but to the continent as a whole, because this is a continental CDC. And I also want to congratulate my colleague who actually started this CDC under difficult conditions. And I'm glad that he's also being honored in the same way. And we must congratulate him. He did a good job. He laid the foundation, and we have a CDC now because he was there, and his colleagues. But I also want to say I accept this with humility, but also on behalf of many people who have worked here, but also African women. And I'm singling out African women because women generally in the world tend to be edited out of history. You can look at all our countries. There are wonderful women who did wonderful things, who ran kingdoms, but they get edited out of history. If they are lucky, it's a footnote. Maybe it's because language informs attitude, because it's called his story, history. So maybe that's why women are not prominent there. But I really want to say thank you with humility. And I wish the ministers of health all the best, because the pandemics are going to be coming periodically. So we need to be ready. And we have confidence in you, but working with the whole of government approach, taking the whole of government approach, that you will protect us and protect this continent. I wish you a very successful high-level meeting. Thank you.
Thank you very much, Your Excellency. I think we should all forget about history and focus on her story. Women have run kingdoms, and we will continue to do so. Distinguished guests, I would like to invite Dr. Muhammad Ali Pate to speak briefly, representing the President of Nigeria. Please join us and say a few words. Thank you.
Excellencies, honorable ministers, distinguished ladies and gentlemen. My name is Muhammad Ali Pate. I'm the Coordinating Minister of Health and Social Welfare in the federal government of Nigeria. His Excellency President Bola Ahmed Tinubu, the President and Commander-in-Chief of Nigerian Armed Forces, had wanted to be here. But as Dr. Keseye mentioned, there are important conflicts that prevented him from being here. So he asked me to come and to read his speech. So I'll be reading the president's speech, and wherever I say I am, it's not me. It's President Tinubu, who is my boss. So I'll be reading his speech. Here I go. He said, I'm glad to address you today at this auspicious occasion in our collective journey towards transformative healthcare leadership in Africa. And let me thank the Committee of Heads of State and Government of Africa, under the leadership of His Excellency, President Azali Assoumani, President of the Union of Comoros and Chairperson of the African Union, for endorsing me as the AU Champion for Human Resources for Health and Community Health Delivery Partnership to the 37th Assembly of Heads of State and Government. I also commend the Africa Union Center for Disease Control and Prevention for all its efforts to revamp public health in our continent. As I address you at this Ministerial Executive Leadership Program this morning on the theme, Impactful Leadership in Health, a whole-of-government approach, I'm reminded of the responsibility that rests upon our shoulders to shape the future of healthcare delivery in Africa. Our continent still grapples with numerous health issues that require urgent attention. Infectious diseases remain a significant burden, such as malaria, HIV/AIDS, tuberculosis, cholera, and the threats of emerging infectious diseases that can devastate our communities and economies. Access to essential health services remains limited, especially in many rural areas, due to factors such as inadequate infrastructure, financial barriers, and most seriously, the shortage of manpower that is aggravated by workforce migration to wealthier countries. Non-communicable diseases, including diabetes, cardiovascular diseases, and cancer are on the rise in our continent, further straining healthcare systems that are already struggling to cope. There is also the critical need to address maternal and child health, as high maternal and child mortality rates continue to claim lives, just as we also must improve reproductive health and the position of women in our society. Addressing these health challenges requires a multifaceted approach involving investment in healthcare infrastructure, training, retraining, and retaining healthcare workers, improving access to essential medicines, and promoting preventive healthcare measures, as Her Excellency also mentioned. Addressing these challenges requires us to adopt a whole-of-government approach, recognizing that health outcomes are intrinsically linked to a myriad of socio-economic factors. For instance, a healthy population is essential for a thriving economy as it leads to increased productivity and reduced healthcare costs. Similarly, education plays a crucial role in improving health outcomes by empowering individuals to make informed decisions about their health and well-being. Furthermore, social welfare policies can significantly impact health disparities, as access to resources like clean water, nutritious food, safe housing, directly affects one's health status. Therefore, collaboration across government sectors is imperative to address the complex challenges that we face. By integrating health considerations into broader policy frameworks, we can unleash the full potential of government's actions to promote the health and well-being of our populations. The concept of health in all policies emphasizes the need for all government sectors to consider the health implications of their decisions. By breaking down silos and strengthening coordination, we can maximize the impact of health policies and initiatives. This approach ensures that efforts to improve health are integrated within various sectors, leading to more effective and sustainable outcomes for all, with government leadership and complemented by development partners who are respectful to this idea of Africans leading the charge in terms of prioritizing where they go on their health and social well-being. And central to this approach is our human resources for health. Health professionals are the backbone of our healthcare system. We must also not only invest in training, but also in creating conducive environments that enables the healthcare professional to thrive. And retaining talent, particularly in underserved areas, demands innovative solutions and targeted incentives to ensure equitable access to health services for all. The true measure of our success lies in our ability to reach the most vulnerable members of our communities, and community health delivery must be the cornerstone of our efforts, fostering partnerships with local stakeholders and empowering individuals to take charge of their own health. By investing in grassroots initiatives and strengthening primary healthcare services, we can narrow the gap between rhetoric and reality, ensuring that healthcare reaches all those who need it most. And collaboration among ourselves is not merely a strategic choice, but it is also a moral imperative. The challenges that we face are too complex and multifaceted for any one entity to tackle alone. We must forge partnerships that transcend our borders and sectors, leveraging the collective expertise, resources, and influence of governments, international organizations, civil society, academia, and the private sector. Together, we can catalyze meaningful change and unlock new opportunities for innovation and impact on our continent, Africa. Not Africa in isolation, but a global Africa, engaged in respectful partnerships with the rest of the world. In our quest for universal health coverage, equity must also be our central guiding principle. Health disparities rooted in socio-economic inequality, gender discrimination, geographical isolation, and other systemic injustices demand political will and targeted interventions to address them. We must listen to the voices of marginalized communities, amplifying their concerns and aspirations as we build a more prosperous, just, and inclusive societies. In Nigeria, according to the President, we are making significant efforts aimed at enhancing healthcare accessibility, affordability, and quality for all our citizens, irrespective of their socioeconomic standing. This initiative that we are pursuing is driven by a multifaceted approach focusing on strengthening leadership and governance within the health sector, optimizing quality service delivery for efficiency and effectiveness. And the Nigerian Health Sector Renewal Investment Initiative, which I unveiled last December, stands as a pioneering endeavor deployed through a sector-wide approach to improve health outcomes at scale. This initiative is strategically crafted to swiftly improve health outcomes, health indicators, and unlock the economic potential embedded within Nigeria's healthcare value chain. Central to its mission is the unleashing of the nation's human capital, alongside the economic prowess inherent in the health sector. The federal government, under my leadership, according to the President, has already signed a compact with all our state governments and development partners in this multi-stakeholder effort to improve health in Nigeria. And key aspect is also the pursuit of local production of essential medicines, diagnostic kits,
and biologicals include vaccines, strengthen research and development. Unlocking the healthcare value chain requires activating private sector talent and investments. In conclusion, I urge each of you to commit to concrete actions and policies that will drive positive change in healthcare delivery within your respective countries and regions. Together, we can build a prosperous, healthier, more equitable future for all Africans in line with the Agenda 2063. And let us remember that impactful leadership in health requires vision, courage, and collaboration. By working together with determination and resolve, we can overcome the challenges we face. I thank you all and sign President Bola Ahmed Tinubu, President of the Federal Republic of Nigeria. So this is the end of the President's remarks that I have read. Thank you very much. Thank you.
Thank you very much. I would like to invite Dr. Douglas Musemboshora, representing the President of Zimbabwe, to say a few words next.
Your Excellency, colleague ministers, ladies and gentlemen, I am also representing the President of the Republic of Zimbabwe, Dr. Emmerson Dambudzo Mnangagwa. My words are on his behalf. He is committed somewhere, but he's already here to attend the 37th annual session for the AU. We in Zimbabwe, we have faced quite a lot of challenges in the health sector delivery. We stand together with all the countries of the AU and support all efforts that are being done by Africa CDC. We have recognized the need to strengthen our manufacturing of our own commodities, drugs, equipment, and vaccination. In our country, we stress prevention, prevention, and prevention. All the time we look at health. Is the prevention which starts, then we come to management later. As Africa, we've faced lots of epidemics, and our epidemic preparedness is lacking. On the manufacturing of drugs, we have also seen that we are depending on the West and Asia. And we as Africa, if we come together and put all our resources together, there's nothing to stop us from coming up with the same manufacturing facilities of world standard. And as such, on the prevention side, we look at vaccines as very, very important. Realized during COVID outbreak, we were behind. And there was a lot of demand for us for the vaccines, which we could not access as we needed. At this stage, some of our countries, especially in Southern Africa, Zimbabwe, and our neighbors, Zambia, were facing a serious challenge with cholera outbreak. And again, we have seen the gap. There are not enough vaccines in the world for us to confront this challenge. Therefore, as Zimbabwe, we stand with AU, we stand with CDC Africa, and support the idea of having a manufacturing plant for vaccines in Africa. I thank you.
Thank you very much for that. I just realized a few minutes ago that as Her Excellency was referencing the powerful kingdoms of women in the past, that we are actually standing in the land of the legendary Queen of Sheba. I couldn't let it go unacknowledged. A woman known for her wealth, her power, her wisdom, a skilled negotiator, a woman known for her fierce independence and intelligence and power and influence in a male-dominated world. She was really, truly a symbol of female strength. Today, we are honored to host an extraordinary health visionary who's been working so hard to reshape the health landscape in Africa, and especially for women and girls. She's a friend to many of us here, especially to myself, and continues to astound me with her commitment, her passion, and great compassion, and always supporting initiatives that lead to true change on our continent. It's my great pleasure to now invite Dr. Sanait Viseha, Vice President of Global Programs at the Susan Thompson Buffett Foundation, and the Chief Advisor to the World Health Organization, Director General Dr. Sanait.
Good morning. Can you hear me? It's wonderful to see everyone, excellencies, dignitaries, Madame Zuma, and the rest of you, all protocols observed. I had to shout out to Madame Zuma, given what we just talked about. You know, when I look at MELP and why MELP was created, it's exactly to do this, to bring our health ministers on the margins of African Union and to get us closer to the African agenda. Minister Mohamed Pate and I spent a lot of time working at other ministerial leadership programs that took African ministers outside of the continent for 2-3 days, where they get excellent training, but they're also exhausted. They're far away, they travel 20, 25, 30 hours to get up at 5 a.m. in the morning, 6 a.m. in the morning, work through the evening. And oftentimes, it's not about Agenda 2063, but the SDGs and other critical global agendas. It was with that intent, and of course, the COVID-19 pandemic, that truly exposed the injustice in this world. And at that time, John Nkengasong, who was leading Africa CDC, was hustling, going around to every meeting, bringing ministers together to make the case for Africa. So it's out of those that MELP was conceived. So I'm really, really happy to be here at the 1-year anniversary. So as I said, it was started with the idea that the solution we need to deliver health for all in Africa is all sitting in this room. And that we did not need to go to necessarily to Geneva or New York to get those experiences. It's also inspiring to see the vision of all of you supported with Jean Kaseya, who's not, I don't see here, but has really been championing over the last year. I have seen whenever there is a health crisis in the continent, like the cholera that we're facing in the SADC region, being able to bring all of you together to say, how do we work together, transnational borders, to tackle continental challenges and prepare the continent to tackle any health emergency. So through the year, it's just been quite inspiring watching all of you come together at the margins of the Regional Committee for Afro meeting in Botswana. We've had convenings in Lusaka, Zambia, at the margins of CPHIA, and now here at the margins of the African Union Summit. For me, I don't think I need to do a lot of convincing to the people in this room about the importance of investments in health and how it is absolutely fundamental to the underpinning of our development goals. And Madame Zuma talked about we can't do that in isolation. So as we heard from her and Minister Pate, this whole of government approach is to say, how do we work intersectionally? How do we work all of you together to tackle these challenges, and it's been frankly quite inspiring. Nigeria has now become one of our largest government partner, where we are working to tackle the issues Minister Pate talked about. I see Minister Yvonne and our partnership in Rwanda. So when I look around the room and I see Minister Dereja in Ethiopia, many of you, I'm quite thrilled, from Tanzania to Sierra Leone, from Senegal to Togo, we are making profound investments and supporting ministers to say, what is it that you need to deliver your mandate? Where is your vision for the continent? And one of the things I want to bring to your attention is maternal mortality. For those of you who read the World Health Organization's report that was released in February 2023, 37 out of 40 highest maternal mortality burden countries are in sub-Saharan Africa. So it's most of us in this room. And we heard about the socio-economic, the social determinants of health. So for me, thinking systematically, how do we create a strong and robust primary health care center, primary health programs that will help us deliver, tackle emergencies, and yet simultaneously deliver for women and girls and children. And for me, we cannot delink maternal health from child health. If children are not immunized, if children do not survive, mothers will continue to have large number of children. I'm from this continent. My mother has 10 children because she wasn't sure how many of them were going to survive. So really thinking holistically on how we're going to tackle these issues through whole of government and whole of society. And I know you have this arduous task of convening everyone to deliver for your community. So know that we are here to support all of you. We at the foundation think the best way to have impact is to put support behind governments, not necessarily create parallel systems that we can government, but rather put and strengthen the government system that can deliver for population at scale. We are extremely proud to partner with others like the Global Fund and the World Bank, GFF, to also unleash more funds that are essentially, if you look at the World Bank, countries' money for every dollar donors give to GFF, countries can borrow $7 earmarked to health. So we are quite excited, and we really see this platform as an opportunity to help African health ministers speak in one voice, prioritize continental issues so that as partners, we can coordinate ourselves and come together to support you deliver on your mandate. So I also absolutely see MELP as an opportunity to build partnerships, collaborations and relationships that are necessary to achieve our collective goals to transform the health and lives of Africans. And please count on us along the way. So thank you very much for the opportunity to be with you this morning.
Thank you so much, Dr. Senait. In advancing a new public order and local manufacturing, Africa CDC is championing vaccine self-reliance by ensuring that Africa produces its own vaccines with the goal of producing 60% of vaccines needed in Africa by 2040. The Director General of Africa CDC calls this the second independence of Africa, and we can only do this together. The Africa Vaccine Manufacturing Accelerator with Gavi is really a very crucial step toward this goal. So, distinguished guests, please join me in welcoming His Excellency Jose Barroso, the Chair of the Board of Gavi, the Vaccine Alliance, to the stage to say a few words.
Good morning, Excellencies, ladies and gentlemen, dear friends. It's a pleasure to be here with you in this forum, part of our very important summit, the African Union Summit, in what is a crucial year for the future of immunization in Africa. If I may, it's for me a great pleasure to be once again in Addis. I came here many times when I was president of the European Commission, working hand in hand with the African Union Commission. I see Madam Zuma, and many leaders of Africa, now not representing the European Union, but representing Gavi, the Vaccine Alliance. I'm really delighted to have this opportunity to address you on this occasion. It's also great to speak about the exciting partnership between the African Union Commission, Africa CDC, and Gavi, the Vaccine Alliance. It is a tripartite that is already helping the people of Africa and which will be increasingly central to delivering a healthy, prosperous, and resilient future on this continent. Excellencies, ladies and gentlemen, this summit is about giving our next generation the best chance to succeed in what is an increasingly unpredictable world. It is a theme that resonates perfectly with Gavi's mission. We know that health is at the heart of peace, and we know that immunity is at the heart of health. For more than 20 years, Gavi has vaccinated over 1 billion children, which means saving millions of lives and yielding. The Alliance is on track to immunize 300 million children between 2001 and 2020 and prevent 8 million deaths. The vast majority of those lives saved are African. Girls and boys will shape the future of this continent and of the world. Ladies and gentlemen, Your Excellencies, by looking to the future, African leaders are making history today. In January, a new era of immunization against malaria, and with African countries became the first to roll out the RTSS malaria vaccine in a non-pilot setting. Building and sustaining this progress is what Gavi must win for this year, for 2024. At the same time, millions more girls are set to receive the HPV vaccine this year, building on the momentum of 2023, saw the largest rollout of HPV vaccines, ambitious goal of reaching 86 million girls in Gavi-supported countries by the end of 2025, helping to banish the specter of cervical cancer for a generation of African girls. This is a true historic. With renewed mission immunization and use the power of immunization within reach. But we must look further ahead. Our tripartite partnership will shape Gavi's future as we move our 5-year strategy and allow getting a taste of the transformative results when we work together. The African vaccine manufacturing is a perfect embodiment of what can be done when we combine African vision and leadership with Gavi's unique public-private model. In a world that seems perpetually in the grip of multiple crises, long-term solution based on an up to $1 billion financial commitment of Gavi to support sustainable growth of the African vaccine manufacturing sector over the next 10 years. The aim is to produce Gavi African continent. Not only, but will help to stimulate investment in a life science and biotechnology ecosystem that can drive economic growth and provide high-quality jobs for the future. This will not happen overnight, but we are confident that AVMA can play a central role in realizing the bold African Union vision that 60% of the vaccine doses in Africa will be manufactured in Africa by and we are not stopping here. At an event in Paris, co-hosted by France, President Macron will be hosting, together with Gavi and together with Africa CDC. Dr. is very committed to this as well. We will launch the investment opportunity Gavi 6.0. The vast majority, over 4 countries, and the Gavi, we hope that you are close to your hearts too. The investment opportunity that now Gavi is launching is a moment to embrace hope in a brighter future, even in an uncertain world. And I'd like to invite you and also the heads of state and government that you are representing to come to that event. Because in my experience, now leading Gavi for some time, it's very important for donors to listen directly to you, to listen to the African leaders, to tell them your real experiences. That will help make us a success of that event and reinforce this global solidarity towards Africa. We know that this investment opportunity is a moment to embrace hope in a brighter future in this uncertain world. We have heard and will continue to hear of the risks and stark realities of conflict, geopolitical tensions, climate change. But when I look back at what we have achieved together, and I think about the new vaccines and innovative technologies ahead of us, I cannot help but look to the future with confidence. Yes, there are extremely difficult challenges, but I continue to think that the way forward is through committed cooperation. We are standing on the cusp of a new era for immunization. Following the breakthrough against malaria, we have the tantalizing prospect of a new vaccine for TB, one of humanity's oldest scourges, before the decade is out. mRNA vaccine technology and AI-powered research hold the promise of new generation of vaccines that can be rapidly adapted as diseases evolve and new variants emerge. Further ahead, we could see vaccines delivered through microarray patches instead of syringes, reducing the burden on health systems and bringing more people within reach of immunization. I think also from that point of view, that's a great opportunity for Africa. And through AVMA, we are sending a clear signal together that African nations will be the authors of so many of the innovations in immunization that are yet to come. Ladies and gentlemen, Excellencies, I hope we can continue to work together to make the brighter future a reality, including, of course, by securing a successful replenishment for Gavi. And I look forward to meeting with many of you over the coming days and also hopefully in our event in Paris in June. Thank you very much for this opportunity. Thank you.
Thank you very much, Mr. Barroso. Emergency preparedness is really a crucial part of the work being done by Africa CDC, and the Emergency Operations Center here is at the heart of that work. And I had the privilege of seeing the center myself, and in a little while you'll also be offered the same opportunity. We're also going to be doing an official photograph in a short while from now with the Director General and with the at least 21 ministers and other distinguished guests here that are in attendance. And our ushers will direct you to the right location for both the photo and for the emergency operation tour. So in the meantime, let's take a short break and catch up with one another and have another cup of coffee or tea, or get on to some of the next parts of the session today. So thank you very much, Excellencies and distinguished speakers, for attending the very first session of today's forum. We'll take a short break and then we will reconvene. Thank you.
of ministers has really enriched me from builds.
There's the adage or the saying that's been going around. It's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve her own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking with one voice. I think that's the way we should go for a better Africa.
What is it MELP, Ministerial Executive Leadership Program?
Ladies and gentlemen, there are some ushers prepared to take you to look at the amazing state-of-the-art Emergency Operations Center. It is a really impressive place that any kind of emergency, any kind of insight, the screens, live streaming data and information, and insights from all the heads of the departments and teams around the continent are easily absorbed in this room, and the information is fantastic. So ladies and gentlemen, there are ushers to take you there to see the Emergency Operations Center. So please take your coffees and your conversation along with the ushers to the venue. I know that you will enjoy it, and at least take a few minutes and have a glimpse of it. It's really worthwhile. Thank you.
There's the adage or the saying that's been going around. It's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve her own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking with one voice. I think that's the way we should go for a better Africa.
What is it MELP, Ministerial Executive Leadership Program? For me, it's not a training. For me, it's a wonderful opportunity that we have to talk to each other, to exchange. It's a wonderful opportunity that we have to think about Africa. Where are we going? What are we doing? How can we work together? How can we have one voice?
I think bringing all of these people together and sharing a common African brain trust, and at the same time having former ministers, former leaders in their own right come and join this group. I think we'll co-creatively looking at diagnosing these problems. We're co-creatively looking at solutions for it. And I think we will walk away from this better informed. We'll work away from this knowing that we will not only be executing and implementing at our country level, but we'll have the resource of the whole continent, of all 55 countries, helping us to work this journey.
As ministers, what role could we play beyond our national borders? What kind of legacy agendas can we craft that goes beyond our national borders to make sure that our countries are safe and the continent is safe, and we have the capacity to implement these initiatives?
I feel that's a much more
change and improve health outcomes for all of us. And Africa CDC is
because one of the things also that I've learned is that many
There's the adage or the saying that's been going around, it's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve her own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking better Africa.
One is it MELP, Ministerial Executive Leadership Program. For me, it's not a training. For me, it's a wonderful opportunity that we have to talk to each other, to exchange. It's a wonderful opportunity that we have to think about Africa. Where are we going? What are we doing? How can we work together? How can we have one voice?
I think bringing all of these people together and sharing a common African brain trust, and at the same time having former ministers, former leaders in their own right come and join this group. I think we'll co-creatively looking at diagnosing these problems. We're co-creatively looking at solutions for it. And I think we will walk away from this better informed. We'll work away from this knowing that we will not only be executing and implementing at our country level, but we'll have the resource of the whole continent, all 55 countries, helping us to work this journey.
As ministers, what role could we play beyond our national borders? What kind of legacy agendas can we craft that goes beyond our national borders to make sure that our countries are safe and the continent is safe and we have the capacity to implement these initiatives?
I feel that I'm much more equipped with more information because again we were able to hear various stories of ministers of health, past, by the way, and present. And among the past ministers, we had very good ministers who really spent a lot of years in the health sector and did great works.
This executive leadership program is intended to help ministers really forge partnerships among African ministers, among collaborators, and within their own countries, a cross-governmental and a whole-of-government approach to strengthen and build a resilient and strong health system.
I think if you work on better diagnosing the problem, you know all of the components of what it takes to be able to fix that problem.
This training of ministers has really enriched me from a technical point of view, because one of the things also that I've learned is that there are many coalitions that you can build.
There's the adage or the saying that's been going around, it's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve her own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking with one voice. I think that's the way we should go for a better Africa.
One is MELP, Ministerial Executive Leadership Program. For me, it's not a training. For me, it's a wonderful opportunity that we have to talk to each other, to exchange. It's a wonderful opportunity that we have to think about Africa. Where are we? What are we doing? How can we work together? How can we have one voice?
I think bringing all of these people together and sharing a common African brain trust, and at the same time having former ministers, former leaders in their own right come and join this group. I think we're co-creatively looking at diagnosing these problems. We're co-creatively looking at solutions for it. And I think we will walk away from this better informed. We'll work away from this knowing that we will not only be executing and implementing at our country level, but we'll have the resource of the whole continent, of all 55 countries, helping us to work this journey.
Could we play beyond our national borders? What kind of legacy agendas can we craft that goes beyond our national borders to make sure that our countries are safe and the continent is safe, and we have the capacity to implement these initiatives?
I feel that I'm much more equipped with more information because again, we were able to hear various stories of ministers of health, past, by the way, and present. And among the past ministers, we had very good ministers who really spent a lot of years in the health sector and did great works.
This executive leadership program is intended to help ministers really forge partnerships among African ministers, among collaborators, and within their own countries, a cross-governmental and a whole-of-government approach to strengthen and build a resilient and strong health system.
I think if you work on better diagnosing the problem, you know all of the components of what it takes to be able to fix that problem.
This training of ministers has really enriched me from a technical point of view, because one of the things also that I've learned is that there are many coalitions that you can build.
There's the adage or the saying that's been going around, it's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve her own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking with one voice. I think that's the way we should go for a better Africa.
One is MELP, Ministerial Executive Leadership Program. For me, it's not a training. For me, it's a wonderful opportunity that we have to talk to each other, to exchange. It's a wonderful opportunity that we have to think about Africa. Where are we going? What are we doing? How can we work together? How can we have one voice?
I think bringing all of these people together and sharing a common African brain trust, and at the same time having former ministers, former leaders in their own right come and join this group. I think we're co-creatively looking at diagnosing these problems. We're co-creatively looking at solutions for it. And I think we will walk away from this better informed. We'll work away from this knowing that we will not only be executing and implementing at our country level, but we'll have the resource of the whole continent, of all 55 countries, helping us to work this journey.
as ministers, what role could we play beyond our national borders? What kind of legacy agendas can we craft that goes beyond our national borders to make sure that our countries are safe and the continent is safe, and we have the capacity to implement these initiatives?
I feel that I'm much more equipped with more information because again, we were able to hear various stories of ministers of health, past, by the way, and present. And among the past ministers, we had very good ministers who really spent a lot of years in the health sector and did great works.
This executive leadership program is intended to help ministers really forge partnerships among African ministers, among collaborators, and within their own countries, a cross-governmental and a whole-of-government approach to strengthen and build a resilient and strong health system.
I think if you work on better diagnosing the problem, you know all of the components of what it takes to be able to fix that problem.
This training of ministers has really enriched me from a technical point of view, because one of the things also that I've learned is that there are many coalitions that you can build.
There's the adage or the saying that's been going around, it's you make the Africa you want. And the Africa you want should be the Africa that's strong, that's confident, that's capable, that's able to solve her own problems. And that leadership starts now.
We need to really work together to make all of the ministers of Africa stronger and speaking with one voice. I think that's the way we should go for a better Africa.
What is it MELP, Ministerial Executive Leadership Program? For me, it's not a training. For me, it's a wonderful opportunity that we have to talk to each other, to exchange. It's a wonderful opportunity that we have to think about Africa. Where are we going? What are we doing? How can we work together? How can we have one voice?
I think bringing all of these people together and sharing a common African brain trust, and at the same time having former ministers, former leaders in their own right come and join this group. I think we're co-creatively looking at diagnosing these problems. We're co-creatively looking at solutions for it. And I think we will walk away from this better informed. We'll work away from this knowing that we will not only be executing and implementing at our country level, but we have the resource of the whole continent, all 55 countries helping us to work this journey.
Good morning and welcome back from the EOC. Before we go into the next session, can we have a photograph to my left on this floor, just 10 meters to the left? Can our ministers, dignitaries, speakers, please move to the left? We'll take 5 minutes to take an official photo and then reconvene here for the next session. Thank you. So welcome back. If we can take our seats so that we can commence with the next session.
Thank you. Thank you. Can I encourage you to take your seats? Yes. So good morning again. My name's Dr. Alex Coutinho, and I have the privilege to work with Africa CDC, heading up the Kofi Annan Global Health Leadership Program. But today we are here for the Ministerial Executive Leadership Program, and you will notice on your tables we have distributed a handbook for ministers that is one of the tools that we use to support ministers in developing their legacy initiatives. We have copies so far in English and French, and if you need more copies to take home with you, please let us know. We shall give you some extra copies, and we are in the process of translating into the other Africa Union languages. But we will talk about that later. My job is to introduce the next speaker, Dr. Ngashi Ngongo, who is the Chief of Staff for Africa CDC, who is going to be talking about the new Africa CDC strategy. As you all know, Africa CDC was born, we call it in English, in a crucible of fire. The fire between Ebola and COVID led to the birth of this child, but this child has grown very big. And now we look to the future. And so Dr. Ngashi will be speaking about that future, and particularly how that future aligns and synergizes with countries so that Africa CDC can continue to collaborate and serve the countries whose mandate it is to support. Dr. Ngashi.
Thank you very much, Alex. Excellencies, ladies and gentlemen, all protocols observed, I do have the privilege to present to you the strategic plan of Africa CDC and also touch on few flagship initiatives that Africa CDC will be more than willing to work with some of you as part of your legacy programs, your legacy projects. Can we get the first slide, please? Thank you. Now, I'd like to cover 3 points. First of all, I'll touch on the context. I think some of each of us already mentioned this morning with our eminent speakers. I will highlight some of the priorities of the strategic plan of Africa CDC for the next 5 years from 2023 to 27. And then I'll finish with the 5 flagship programs that are extracted from the strategic plan, areas of collaboration with the member states, as Alex just mentioned. Now, let me start with the context to say that we are in a continent that has seen over the last 70 years the emerging and re-emerging diseases. I think that make the mandate of the work that we are doing to help the member states strengthen their health security responses, starting from the 1950s with chikungunya, moving into the 60s with Zika virus and Marburg hemorrhagic fever, in the 70s with Ebola virus that some might remember in the DRC, and monkeypox, and then in the 80s with the advent of the HIV epidemic, in the 90s with meningococcal meningitis, in the 2000s with cholera and bubonic plague, in the 2010s with measles and yellow fever virus, and finally in the 2020s, 2020 with the advent of the COVID-19 pandemic. I think that's the context in which the Africa CDC is now established to help the member states respond to that. Now, when we look at the number of health emergencies that have been reported in Africa since the 70s, one main observation is that both in terms of the numbers of outbreaks that are reported, and also the number of emerging and re-emerging diseases, as we've seen a very significant increase on the continent, which could be summarized as, if we look at every 10 years, the number of emerging and re-emerging diseases, I think that has increased 4 times since the 1960s until where we stand now. And also that if we look at every year, the number of outbreaks that are reported on the continent, that number has also increased 3 times. Just to say that really the pressure is just increasing really on our member state to respond to all these public health threats and outbreaks. The situation of 2023 just confirmed that at Africa CDC we had 166 public health events and outbreaks that were reported. If you take that as an average, it comes to about 3 events reported every single week. I think that's really a lot of work. And also, I think we are aware of the ongoing outbreak, cholera outbreak on the continent. If you look at just the most recent data comparing 2023 and 2024, we just picked at the first 6 weeks of the year 2023 compared with the first 6 weeks of the year 2024. We are seeing a big change, really an increase, both in terms of the number of cases, but also in terms of mortality. Just to say that the situation is just deteriorating. I think that is the context in which we are operating. I think that's also the context in which the new strategic plan of Africa CDC was developed for the next 5 years. I think just to say, before we come on to the priorities, that Africa CDC is a very young organization. I think a couple of weeks ago, on the 31st of January, we celebrated the 7th anniversary of Africa CDC. It's a very young organization, but that came into play rapidly, faced by so many considerable challenges that we started responding. In 2027, in January, that was the establishment of Africa CDC. And the same year also, we developed our first strategic plan. In the year that followed, in 2018, already we started responding to outbreaks, at least 6 disease outbreaks that we responded in 9 member states. The following year, in 2020, we were confronted with the COVID-19 pandemic. And we are proud to see that Africa was the only continent with the support of Africa CDC that developed the joint continental strategy to respond to COVID-19. In 2021, we launched the massive 1.5 billion Saving Lives and Livelihood program to respond to COVID. And the same year also, we did launch the partnership for vaccine manufacturing to push the local manufacturing of vaccine that we heard also some of the speakers this morning, and launched the first international conference on public health in Africa as a platform that we can really share the science around public health and the continent, but also exchange some of the lessons and successes to help us improve our public health responses. And the year that followed, in 2022, then Africa CDC was granted its operational autonomy by the head of state. And then last year, in 2023, we developed the new strategic plan that I'm going to talk about briefly. But just to say that this plan, as you are going to see, is very much aligned with the main agenda of the main health and development agenda on the continent, starting with the AU Agenda 2063 of the Africa We Want, the health strategy 2016-2030, the new public health order that was released in 2022, and also the global context and the global framework, in particular the Sustainable Development Goals. And that it is also grounded on solid analysis, first of all, of the disease outbreak on the continent, the public health systems and institutions in Africa, but also building on our lessons of our 7 years since we have been established, and taking also into consideration some of the important trends and opportunities that are offered to us. Now, the strategic plan could be summarized just in this one single slide, which we call the House of Health, which first of all defined the vision aligned with the Vision 2063 of really helping to build this safer, healthier, and prosperous Africa, in which every member state has the capacity to respond to public health threats. But our mission, most importantly, is to ensure that every single one of our 55 member states has public health institutions and systems that enable them to detect and respond to outbreaks in a timely manner. But for us to achieve that, I think we also came up with an aspiration for ourselves that as a continental agency, we need to become a world-class, self-sustaining and agile institution that can not only champion public health, health security on the continent, but also set the agenda and lead and coordinate our collective effort. Now, in terms of the key priorities that were identified, 6 programmatic priorities we would like to share. The first is to ensure that on the continent, we have integrated health systems that are able to prevent and control high-burden diseases. And with a greater focus on primary healthcare, and within the primary healthcare is also a stronger focus on community health, with community health workers towards the AU target that we are all aware of 2 million community health workers on the continent. The second programmatic target is on building proactive surveillance, intelligence gathering, and early warning systems that we are really very much pushing the One Health approach, and also emphasizing on starting from the community with the events-based surveillance that can allow us to identify early and timely some of these threats, and also model the response that can stop this threat right from the beginning. The third programmatic priority is the emergency preparedness and response capabilities that need to be strengthened to be able to respond to public health emergencies. Under there, we are looking at 3 components mainly. The first component is the preparedness in all our member states. The second component under there is the timely response and recovery. And then the last is the cross-border collaboration, learning even from what we are seeing now, that a threat in one country, with the way that we are now linked between our countries, has the trend of also spilling over to the other countries. That's why there's this emphasis on cross-border collaboration. The fourth programmatic priority is to strengthen National Public Health Institute. I think we have, at the moment, less than half of the member states on the continent that have functional public health institute. That our effort is to make sure that by the end of this strategic plan, every one of our 55 member states does have a functional institute that can lead health security agenda in the country. The fifth programmatic priority is to expand the clinical and public health laboratory systems and networks, looking at building the infrastructure, strengthening the capacity, expanding the diagnostics, expanding pathogen genomics. I think very important to ensure that every one of our member states has the capacity to diagnose and do the sequencing of different pathogens. And finally, is the expansion of the local manufacturing, as we heard already this morning, that this could be the second independence of our African continent. But in addition to these 6 programmatic priorities, we also identified 7 enablers, very important to also help us achieve on those programmatic priorities. Enabler number 1 is the digitalization agenda, that now we can digitalize our system to improve the quality, to improve the timeliness, to improve the efficiency. And the second important enabler is to scale up the public health workforce. That remains a major challenge on the continent. The third important enabler is to address the issue of the financing, to ensure that we have sustainable financing on the continent, and most importantly, to be able even to respond on day 0 in case of an emergency. The fourth enabler is the agenda of research and innovation, to ensure that we have research that is focused on our needs on the continent, on the African continent. And the fifth enabler is the partnership, that we really want to be respectful partnership that are based on the needs of the African continent, but action-oriented and result-based. But those partnerships that we see not only with our donors and international partners, but most importantly, the partnership that we want to build with the African communities themselves as a key player into our effort to address public health threat on the continent. And the sixth enabler is the engagement that we want really to intensify with our member states through our regional collaborating centers and then our country offices. And finally is within Africa CDC itself, ensure that we have improved the governance and also the internal structures and processes that allow Africa CDC to be able to deliver on its mandate. I think those are the 6 key priorities of the next strategic plan that will be the focus of the work of Africa CDC over the next 5 years, and also the 7 enablers that we think are important to allow us to deliver on those priorities. But in terms of implementation, for us to deliver, I think Africa CDC, as you know, has got its uniqueness in terms of the governing structures that support the work of Africa CDC, starting with the Advisory and Technical Council, which is made of some of the technical experts from our member states that do provide technical and strategic guidance to the work that we do. And above the Advisory and Technical Council, we have the Governing Board, which is composed of the health ministers, 10 health ministers, 8 that are now established already, because we are still waiting for the 2 from the north. That the Governing Board's role is mainly to provide the strategic guidance to the work and also ensure that the work that we do is fully integrated into continental strategies, and also help us think through the resource mobilization that is important for us to get the needed resources to support the public health agenda on the continent. And then above the Governing Board, we also have the Committee of Head of State and the Government that include 10 head of state, the 5 sitting members of the Bureau, and also 1 head of state representing each of the 5 regions of Africa CDC. But in addition to that, we continue to get the support from the AU policy organs such as the PRC, the Executive Council, and the AU Assembly that also do support the work that we do. But at operational level, Africa CDC is now expanding really to strengthen its capacity in the regions. We have the regional collaboration centers in each of the 5 regions. And in addition to that, we are also strengthening our country presence so that in every country we'll have an Africa CDC team where we have NPHIs that are already established and functional. Those teams will be sitting within the NPHIs, And where the NPHIs are not yet established, the Africa CDC country team will be seated with the Ministry of Health. I think it is that proximity to the member state that we hope will be critical really to help us provide the needed support to our member state to advance the public health agenda on the continent. Now, before I finish, out of those programmatic priorities that I just mentioned, we have identified 5 flagship initiatives that will really benefit from an intense support from Africa CDC. I think these are the flagship initiatives that would be more than willing to support the members of the MELP, to pick them as their legacy project. I think I would like just to go through them. I think the first is on the protection of the front line healthcare workers, protecting the people that protect us. Very important. I think one of the reasons why this was identified, it's because we know that we still have a huge shortage of healthcare workers on the continent. But the observation is that health workers have been the victims and on many of the outbreaks that we face on the continent, and also a major risk of the amplification of major outbreaks. If I just take the example of some of the important ones that we've experienced recently, the Ebola outbreak in West Africa and also the recent COVID-19 pandemic. During the Ebola outbreak, it was observed that 8% of healthcare workers died compared to only 0.11% of the general population. I think that to say that mortality was highest among healthcare workers compared to the general population in Liberia. During the COVID-19, I think WHO reported that between January 2020 and May 2021, just that period, there were already 115,000 health workers that had already lost their lives to COVID-19. I think that's why it is so important for us to protect the healthcare workers, because they are our defense mechanism. And in addition to that, it is clear that infection prevention and control has been proven to be an evidence-based approach to protect healthcare workers. And the evidence that was published by WHO in 2022 says that good IPC programs can reduce infections in healthcare system by as much as 70%. I think that is the reason why the protection of healthcare workers is one of the key flagship initiatives that has been identified by Africa CDC. Can you please help move on to the next slide? It's not working. Now, I just want to touch a little bit on some of the key actions that we are going to support to advance this key flagship initiative. The first action is to ensure that we constitute a database with the geolocalization of all healthcare workers in every one of our 55 member states, so that we can know how many health workers do we have and where are they, to be able to organize some targeted interventions. That is the first action. Now we have some estimate from WHO that gives us, we have about 4 million healthcare workers on the continent. I think this is the data that we would like to update, in every one of our member states. And then the second action we'll also have is the vaccination of healthcare workers within the life course vaccination, just following also the protocol that is approved in the country to ensure that all our 4 million healthcare workers are fully vaccinated. And finally, it's to ensure that in every one of our healthcare facilities, we have both the infection prevention and control measures and also the water water, sanitation, and hygiene facilities to be able to protect the healthcare workers. It is the combination of those two interventions, the vaccination on one side, but also the IPC that we hope will help protect our frontline healthcare workers. Now, the expected impact first of all is the reduction of the overall infection among healthcare workers in the primary health system, but also the reduction of outbreaks and also the prevention of them from becoming epidemics or pandemics. The realization that every pandemic always first starts as an outbreak before it can expand. And finally, is to curb the mortality among our healthcare workers. Now, the second flagship program is the strengthening of our primary healthcare system. Through there, we are looking at two things. One is the digitalization of our primary healthcare system, and then the second is the scale-up of community health workers toward the AU target of 2 million community health workers. Now, the data shows clearly that on the continent, only about half of Africans do have access to primary healthcare services. I think that is already a problem of equity, in terms of equity of access. In addition, we all know that the data from WHO shows that we have a huge gap in health resources for health, estimated at about 4.2 million. And also, that now almost 6 years after the AU target of accelerating the scale-up of community health workers to achieve the 2 million target, I think the data that is available shows that we are still below 1 million. Around 600 to 700 community health workers that are on the continent. We see that the journey is still really very far from where we want to be. Yes, there is an opportunity on the continent that the digitalization connectivity that is possible, because about 81% of the population living in sub-Saharan Africa, for example, the data that we have is covered by a mobile network. That means that we have an opportunity really to scale up the digitalization if we did invest in that space. Now, some of the key actions that are considered. One, is to ensure that every single facility has got access to a digital technology, but also to the internet connectivity and to the solarization. So that we can have a regular and timely contact with the most remote public health primary healthcare facilities. And secondly, we would like to accelerate the AU agenda around community health workers to move toward the target of 2 million community health workers. And finally, is that we have now an opportunity as we move forward to move toward an integrated package of community health, community-based services that also look at both the program services, but also health security with the integration of event-based surveillance. Now, the expected impact to see an enhanced public healthcare delivery system that pushes for the equitable access to services on one side, but also provide quality services and is able to also facilitate the real-time surveillance of key public health threats. The third flagship initiative is to really strengthen the continental pathogen genomics, bioinformatics, and data quality. That to recognize that on the continent, we continue to be exposed to new viruses, as I just showed the map of imaging and re-imaging diseases, that good laboratory capacity on the continent will help us to rapidly investigate the spread of outbreak, but also improve our surveillance and our outbreak detection to be able to respond in time. But when we look at the most recent data on COVID-19, it shows that Africa only contributed less than 2% of all genomic sequencing. And most of that came from one single country, that was South Africa, that contributed 40% of the genomic sequencing. That means we still have a very huge gap to ensure that we scale up the capacity to do diagnostic and genomic sequencing across all the other member states. I think that is the focus of this, this flagship, that to be looking at, on one side, the strengthening of the infrastructure and human resource capacity for diagnostics and pathogen genomic sequencing in all our 55 member states, but at the same time also establish the Africa CDC Genomic and Bioinformatics Center here at Africa CDC that some of you might want to visit on the other side, just outside this building. And as the expected impact on that is really to improve access to timely diagnostics on the continent. I think some of you remember that the Omicron, I think the Omicron was discovered in Botswana with the equipment that was actually donated to Botswana as part of this strengthening of the member state capacity in genomic sequencing. I think that's why we would like really to replicate that in all our member states, but also we expect that with that to be able to get a rapid and early detection and response to high consequence pathogens. The fourth flagship initiative is the strengthening of National Public Health Institute. Very important for us because we know that National Public Health Institute are actually the coordination platform for the national health security agenda that is important to lead our emergency preparedness and response on one side, but also be the focal point for the international health regulation and the point for the generation of the evidence to guide public health policies and practice. Now, the situation now shows a huge gap. It's about 50% of our member states that still do not have functioning National Public Health Institute. We have 25 member states that have already established one, 19 member states that are in the process of establishing, and 13 member states that haven't yet established. I think that's the gap that we really want to fill. But most important, a very good National Public Health Institute must also have an emergency operations center. As of now, we only have 12 member states that do have functional emergency operations centers. Now, the action in that space is to establish the National Public Health Institute in the remaining 32 member states which still do not have functioning NPHIs. And at the same time, it's also to strengthen the functionality of the already established 2023 NPHI. With that, we also aim to ensure that in every National Public Health Institute, there is an emergency operations center that is functional. And out of our 5 regions, I think the aim is to identify at least 2 National Public Health Institutes that will play the role of centers of excellence to support the other member states in the region. Now, the expected impact on that is really the enhanced member state capacity for outbreak preparedness and response, and also have an advanced capacity of the regional centers of excellence. Now, to finish, the last and final flagship initiative is the strengthening of the regional local manufacturing that we've also had the effort that are being made in Nigeria, for example, that Minister Pate just presented this morning. The sad reality is that our continent, with its 1.3 billion people, only produces 1% of its vaccine needs. It produces only about 5% of its needs in terms of diagnostics, and about 30% of its therapeutics. I think that is what we like to reverse with the commitment of the AU member state, that by 2040, we need to reach at least 60% of all the vaccines that we use that are produced on the continent. And we want also to push the same target even for diagnostics and also for therapeutics. Now, what the member state can do to contribute to this local manufacturing agenda? One is to create incentives for the private sector engagement. That means engagement by improving access to financing, important role for domestic resources, but also to create some enablers for medical industrialization. I think we have now on the continent some good practices that are very important. We have the experience with Morocco. We had a really very interesting meeting in Morocco last year that we visited. I think the work that is done in that country, how the Kingdom of Morocco is investing its own domestic resources, into the private sector to stimulate the local manufacturing of vaccines. We also heard this morning Minister Pate also telling us about what Nigeria is also planning to do. I think it's extremely important that as a member state, we create those incentives really to stimulate the private sector to engage. And secondly, it's also the strengthening of our national regulatory capacity to ensure that those products that are manufactured on the continent can be registered for use in our countries. And finally, and most important, is that we need to support the food procurement to be able to create the volumes that are necessary to sustain the market for local manufacturers. Now, in terms of impact, I think the aim is to go toward the 60% production of medical products that are used in Africa that has to come from local manufacturing. And most importantly also is to attain regulatory excellence. I think those are, to finish, the 5 flagship initiatives that Africa CDC is very much willing to work in collaboration with countries and also provide the support for those members of the MELP that will decide to pick some of those as their legacy project. Thank you very much for your attention.
Thank you very much, Dr. Ngashi. As you can see, in the years past, people might have said, oh, we have Ebola, Africa CDC come and help us, or we have COVID, or we have now cholera. But the strategy builds on all the accomplishments historically, and we have an Africa CDC that is there to serve member states. These days I teach leadership in many fora, and there are many types of leaders, but for me, my favorite leader is leadership through service. When you're a leader who is there to help and serve others, I think you are the best leader. And that is what Africa CDC is striving through its strategy to be available, to work with, to collaborate with, and to serve countries in their need. So we are pressured for time, but in case there is a question or a clarification, Dr. Ngashi will be happy to answer that. This strategy is available on the Africa CDC webpage in all of the AU languages. So let me check. Is there any individual who would like a clarification question? Dr. Ngashi will be available throughout the day as well to answer any queries. So Dr. Ngashi, thank you very much. It seems you are very clear, and people will reach out to you at lunchtime. Oh, is there a specific question? Sorry, did I miss a hand? I think we're good. Yes, thank you very much. A round of applause for Dr. Ngashi. So we are now moving, we are slightly late, but we will catch up. We are now moving very much into discussions and panel discussions. MELP would not be what it is without our MELP advisors, and I would like to introduce them now because they will be moderating the session. We have 3 senior MELP advisors, all of them who have been ministers of health, 2 of them who are here. The first who will be moderating the first session is Professor Nicholas Meda, former Minister of Health, Burkina Faso, who is on the left and kindly joined me on the platform. The second is Dr. Magda Robalo, who is former minister, also seated on the left, of Guinea-Bissau, who is a MELP advisor. And our third advisor is Dr. Kesete, former Minister of Health for Ethiopia, who is not here with us in person, but in spirit he's with us. So I'm going to hand over to Professor Nicholas Meda, please, who will be moderating and inviting the panel who is going to talk about
the first session, which Professor Meda will be explaining. Professor Meda.
Thank you very much, Alex.
You can speak in French.
So he said me to speak in French. So c'est un plaisir pour moi de parler en français. Je commence doucement pour que les gens mettent leurs écouteurs. Cette session va concerner la sécurité sanitaire mondiale, la sécurité sanitaire de l'Afrique. Et nous avons des panélistes de très haut niveau pour introduire la question et partager leur expérience sur l'actualité en matière de reconfiguration de l'agenda de sécurité sanitaire mondiale, partager les collaborations et les expériences de l'Afrique en matière de sécurité sanitaire de l'Afrique et des pays africains, et surtout partager aussi les premiers moments de l'application de certains instruments qui ont été mis en place pour accompagner la sécurité sanitaire. Il s'agit du Pandemic Fund que tout le monde connaît et Africa CDC a aussi signé des accords avec l'OMS pour travailler ensemble à répondre ensemble aux urgences de santé publique en Afrique. Et donc, je vais maintenant inviter Dr. John Kengasson à venir au niveau du panel. John Kengasson, sous vos applaudissements, s'il vous plaît, n'est plus à présenter. C'est le premier directeur de Africa CDC. Maintenant, il est ambassadeur des États-Unis d'Amérique pour la santé mondiale et couvre différents agendas. Et un principal agenda, c'est vraiment garantir la sécurité sanitaire mondiale et aussi celle des États-Unis. Je connais John depuis peut-être 30 ans, quand il dirigeait le laboratoire du projet RetroC de CDC à Abidjan. On était tous des jeunes chercheurs à cette époque et on a mis en place les premiers essais de prévention de la transmission mère-enfant du virus du sida en Afrique. John, c'est à partir de cet instant qu'on a cheminé ensemble, mais vous avez tellement, comme disent les Ivoiriens, percé que je ne vous ai plus rattrapé. Donc merci d'être là. Le second, c'est l'honorable Sylvia Masebo. Honorable Sylvia Masebo is a Minister of Health from Zambia and was a mother of CPIH in Zambia last November. And you all know Sylvia Masebo, a very integrated and very social minister, and we all remember the welcoming, the great welcoming we received when we were in Zambia last November. Merci beaucoup, Sylvia, pour votre présence. Je vais maintenant inviter Dr. Boutera, le ministre d'État, Minister of State from Rwanda, qui représente le ministre Sabine Sanzimana, que vous avez comme nom dans le programme, mais il est représenté par le ministre Bitera qui parlera de lui et de l'expérience du Rwanda. Enfin, nous avons Dr Saed de Libye. Dr Saed, voilà, vient et certainement va parler de l'expérience de la Libye en matière de gestion des urgences. La Libye a été frappée par des inondations massives ces derniers temps et je pense qu'il a l'expérience vécue et la collaboration avec Africa CDC à partager. Sous vos applaudissements pour Dr Saed. Les autres membres du panel, malheureusement, n'ont pas pu faire le déplacement, mais le panel est suffisant. Et donc, le panel va couvrir à peu près 5 points. Premièrement, définir ensemble et comprendre ensemble ce que c'est que la sécurité sanitaire mondiale et qu'est-ce que cette sécurité sanitaire mondiale représente pour l'Afrique. Vous savez tous les négociations en cours pour le Pandemic Treaty. Vous savez tous la révision en cours du règlement sanitaire international. C'est des choses sur lesquelles nous allons revenir. Ça va couvrir aussi toutes les implications des nouveaux instruments de gestion de la sécurité sanitaire actuellement dans le monde et en Afrique. Je parle du Pandemic Fund, je parle de l'accord entre l'OMS et Africa CDC pour agir ensemble en cas d'urgence. Et nous allons partager les expériences des différents pays qui ont été les premiers récipiendaires du Pandemic Fund cette année. Et le premier intervenant va être le docteur John Tengason, qui va nous planter le décor en matière de sécurité sanitaire mondiale, de sécurité sanitaire de l'Afrique et de l'apport des partenaires en général pour faire progresser cette sécurité sanitaire. John, s'il vous plaît, vous avez la parole.
Merci Nicolas pour l'introduction. Merci beaucoup. Vous êtes toujours jeune. Je demande toujours pourquoi tu restes si jeune après 30 ans. Colleagues, it's a pleasure to be at Africa CDC and to share the podium with such distinguished panelists. But let me first of all start by acknowledging the presence of, or not, of the distinguished ministers who are here, and the Director General of Africa's CDC, Dr. Kasser, who is not here but was with us in the morning, Chairperson Zuma. Once chairperson, you remain chairperson forever, so it was an honor to be with her this morning. Colleagues, distinguished delegates, really a pleasure to have been asked to frame this conversation. So, because of time, I would like to keep my remarks very, very short. So the starting point, as Nicolas said, was the global health security agenda. I always, when you listen to those words, like universal health coverage, the first question I always ask myself is, what is the problem that we want to solve? And simply put, the problem we want to solve is to ensure that an emerging disease shows up, and we have the capacity and capability to guarantee the safety of everybody in the world. We've recognized that an emerging threat anywhere in the world is a threat everywhere in the world, and it very quickly becomes a national security threat because it affects the health I was in Nigeria in September of last year with Mr. Tuji is here and the Minister Pate just left. And Minister Pate took us to Kano and we visited the Murtala Mohammed Hospital, one of the largest hospitals in West Africa or in Africa. We walked into a ward and the ward was as big as this conference room. And it was full of children that were going through hell. I've never seen a scenario like that, where their mothers were sitting next to them. These children were grappling for their last breath. It wasn't HIV. It reminded me of HIV 25 years ago, where you walked into a ward and you saw a skeleton of people dying, but these were children dying of malaria. I looked into the eyes of these mothers sitting there, and that ward was really hot, and they were fanning their children. They looked at me, they didn't say anything, and that silence spoke volume. He said to me, do something, help us. My child is dying. The only thing that mattered for that woman at that time, sitting desperately looking at you, was that dying child. The Minister Pate turned to me and said, John, this is what it is when public health fails. Because those children that were in that ward could have been prevented. That scenario could have been prevented. I start there because if you cannot prevent that massive failure of public health, how are we going to prepare for a fast-moving respiratory disease threat that has the ability to cross 20 million deaths in 3 years, or has the ability to cause a case fatality rate of about 15%. So investing in the knowns is extremely important for global health security. Malaria has been around since 1897, when Roland Ross identified that malaria was caused by a parasite. And since then, the first malaria programs, control malaria programs, started in 1902. Yet today, malaria, a disease that with good public health practice, we could avoid that scenario in Kano, still prevails with us. Invest in your HIV programs. HIV is not over. HIV is a security threat, it's a developmental threat, and is a health threat. We all know that 60% of deaths of HIV are occurring on the continent. Last year alone, more than 425,000 people died on the continent because of HIV. So HIV is not gone. So investing in those platforms, using HIV as a platform that has killed millions of Africans, is important so that we get to a destination of 2030, which we have agreed to bring HIV/AIDS to an end as a public health threat. My last comment is partnership, that there is no global health security without partnership. And let me then comment as the head of the Bureau of Global Health Security and Diplomacy at State Department, which we manage the HIV programs. Through the partnership with you ministers here, we have saved 5.5 million children born free of HIV/AIDS. We have saved 25 million lives in 20 years, and we continue to invest at least close to 6 billion a year on the continent in supporting your efforts. HIV/AIDS is not over, but it's a platform, and we are committed to continue that effort until we get to a target of 2030, which we all agree we should bring HIV/AIDS to an end. It's a platform because if we build on that and develop diagnostics, which we have committed as US government, that we will buy 15 million HIV rapid tests if they were made in Africa. We have also committed that we will buy 2 million ARV tests if they were made in Africa. And we are working very closely with the Global Fund so that they also commit to enable the market. And that will be in full alignment of the 5-year strategic plan that Africa CDC just presented. That is the power of investing in the knowns. And that is the power of partnerships. Secondly, is that we continue to be big contributors to the pandemic fund. The pandemic fund has raised close to $2 billion, and we've contributed about $750 million as the US government to support that fund. We are currently leading the 5-year strategic plan development for that fund, and we hope and look forward to a very strong partnership with the African Union to grow that fund. Thirdly is the pandemic accord. The power of partnership says the moment is now for us to come together and make the pandemic accord a reality. We have just till May of this year to conclude the pandemic accord, which will be a very powerful instrument to govern our health security. The United States hope that a strong partnership with the African constituency in Geneva will enable us to cross that bridge and have an agreement or an accord that will be usable and practical for everybody. Professor Beda, I hope that is the framing that you wanted us to start with. Yeah. I'll turn the microphone back to you.
Merci beaucoup à Dr. John Kengasson pour ses remarques introductives à nos échanges autour de la sécurité sanitaire mondiale et africaine. Nous avons, pour ces échanges, compris à travers l'introduction de Dr. John Kengasson que la sécurité sanitaire est impossible sans le partenariat. La sécurité sanitaire, c'est vraiment la collaboration des nations pour mieux protéger les populations, la collaboration des nations pour prévenir, mieux détecter et répondre au mieux à toutes les urgences. Et c'est dans ce sens que Africa CDC et l'OMS en Afrique et au Moyen-Orient, donc EMRO et AFRO, ont signé un accord pour agir ensemble. Et cet accord repose sur 3 piliers. Premièrement, renforcer ensemble les capacités de surveillance pour mieux détecter les événements, prévenir ce qui est possible et se préparer à répondre rapidement aux événements qui deviennent des épidémies avant qu'ils ne soient des pandémies. Deuxièmement, agir ensemble, car pour répondre dans les 24-48 heures, il faut des vaccins, il faut des médicaments, il faut des commodités, des dispositifs médicaux. Et ça, l'OMS, vous le savez, en Afrique, a établi un hub au Sénégal pour permettre que dans les 24-48 heures, quand il y a un événement épidémique, que la réponse soit rapide et appropriée à ce niveau. Et Africa CDC travaille avec l'OMS dans ce sens. Et troisièmement, le pilier des ressources humaines. C'est tout ça l'agenda de renforcer les ressources humaines en Afrique pour que les équipes d'intervention rapide disposent des capacités pour être sur le terrain et mieux répondre. Voilà le Joint Emergency Action Plan entre Africa CDC et l'OMS pour travailler en partenariat pour le bien et la sécurité sanitaire de l'Afrique. Les panélistes qui sont là, nous allons essayer après les remarques introductives de John, les interroger sur un certain nombre d'aspects et John pourra contribuer ensuite chaque fois que possible. So, with all the panelists, we will cover first what health security means for the country. We have here Libya, we have here Rwanda, we have here Zambia. Based on what John said and what you know about the agenda of global health security, from your country, what global health security, what African health security, what your own country health security means, and what you are doing to advance this agenda. Perhaps we will start with Honorable Masebo first, and then continue with my friend Butera, and finish with Dr. Syed. It's not working?
It's working. Your Excellencies, dear colleagues, distinguished guests, ladies and gentlemen. First of all, just to thank Chairperson for this opportunity. We are here to learn, and we continue learning. And one of the lessons that we learned this morning was simply that health cannot stand alone, and that there are various factors that influence health, and those are what are called health determinants or determinants of health. And because of that, obviously, one of our lessons is that in whatever we do, especially as we fight diseases, we have to work with other sectors in order to get better outcomes. So for Zambia, we realized a long time ago that we could not stand on our own. So in country, we deal with pandemics through a multi-sectorial approach. And it is this approach that has helped us to really be able to fight pandemics. And also to say that as a nation, we have in place what we call the Zambia National Public Health Institute, which is, I would say, doing quite well, considering that it was established some few years ago, and like others, and we are at the stage where now we are able to get the benefit of having an institute. And Zambia also does host the Southern Region REC, and because of that, I can safely say that we are at the level where whenever we have a pandemic, we are able to respond. As you know, recently we had an outbreak of cholera, which actually started in October, but became severe just after Christmas. And so between Christmas and the end of January and the first week of January, just the first week of January, we had a situation wherein we had over 500 people who have since died from cholera. This is not the first time, of course, that Zambia has had this problem of cholera, considering that we are a landlocked, or what we call a landlocked country. And so after the outbreak of cholera in Malawi and Mozambique and then Zimbabwe, there was no way that Zambia would not have cholera. And I think this is one point that we all need to realize, that unless we work together, Africa will never be safe. So we need to get to a point where we realize that when it comes to outbreaks, there's no one who is safe. And therefore, the need to work together becomes even more obvious. And of course, the need to strengthen our health systems, and in fact, our preparedness even becomes more important. But one issue that I learned, I was actually very lucky, I should say, because of course we had the conference, and alongside the conference, the Sophia conference that we had in Lusaka in November, we had the training again. You know, that was our first ministerial training. And I must say that my experience in that training did help me to face the cholera outbreak in Lusaka, which was the epicenter of the disease. And from those lessons, one of the things I did was to immediately make sure that we have an interministerial task force on cholera of key ministries, those that are dealing with water, sanitation, those that are dealing with housing, and those that are dealing with issues of law and order, just to mention a few. So we're about 6 ministers, and I, as Minister of Health, was chairing that ministerial task force on cholera. Of course, we have already in place as a nation an interministerial committee that is chaired by Her Honor, the Vice President, that looks at all epidemics in the country. But underneath that, we had to create this one. And we were able, working with everybody else, we were able to make great progress. And I think one of the issues also that came out was that there was effective political leadership from myself and my colleagues, and of course under the leadership and stewardship of His Excellency the President, Mr. Hakainde Hichilema, and Her Honor the Vice President. So we're really able to work as a collective body, and also important was also issues of funding that, I was happy that at least the government had to mobilize internal resources to show that, it was our own baby, even before we looked out to others, and enough resources. Anyway, resources are never enough, but at least good numbers, different resources came on board, including human resource. We're able to mobilize internally, staff from the various health facilities within the country. And we also, of course, we did make an application to the pandemic fund. We also made an application to WHO and also to Africa CDC. So in terms of resource mobilization, we were able to get support from various partners in country and out country. So I just want to use this opportunity, obviously, to thank Africa CDC, to thank WHO, and to thank all the other partners, UNICEF, that came on board. And WHO, Afro, was also very good in terms of resources. They were also able to give us just less than $1 million, but they also gave us technical support. And we were able to use this resource to strengthen, of course, our institutes in terms of surveillance and all that is required. And I must say that we managed to establish one of the biggest hospitals that one had ever seen. But we used one of our big stadium, which is used for football. We turned that into a temporal cholera center. So it was, and this hospital had close to 1,200 beds, and at one point during the pandemic, we had 1,050 patients in bed at one time. Let me also say that we were lucky in that we also had international organizations sending experts to come and work with us, but very importantly was the use of our community health workers and the volunteers that came on board to actually help us with this disease control. And let me also just say that the work of the community health workers was so important, in that without them, we're not going to manage to achieve the results that we achieved. At the moment, I'm happy to say that the numbers have gone down. Whilst we used to have close to between 200 to 500 new cases every day, now we are reporting less than 100 cases nationally every day. when we had double digits of deaths, people dying, 20 every day, 15, 25. Now we have 0, and at times we have 1, less than 5. And so we're at a point where we can safely say that within 5 to 6 weeks, we're able to stabilize the situation. And all that is around collaboration, partnerships, all that is around leadership, political leadership, all that success was around resource mobilization, and of course part of the fact that the pandemic fund was one of those resources that we were able to give us the good results. But most importantly, I want to state that preparedness is also something that we were lucky in, that by the time we were getting to a stage where things were really tough, we were able to sail through because obviously of our experience from the COVID time, but also because we were able to work together using a One Health approach and also using a whole government approach. I thought I'd just use this opportunity also to talk about the experience of COVID whilst talking about the issue of health security in the nation and globally. Thank you very much.
Thank you very much, Honorable Masebo, for this insightful talk, where if I remain only one thing is you develop what we call the plan for crisis management. Always to have a plan. Second, to have a group of people. You are talking about the task force of ministers, the Zambia National Public Health Institute, and others, and funding to react rapidly. So these 3 elements is important for each ministry to deal with national health security. Thank you again, Honorable Masebo. We will come late to you. But now, let's speak with Dr. Boutera. Dr. Boutera, le Rwanda est vraiment spécial dans sa capacité à gérer sa sécurité nationale en termes de santé. Et peut-être, au-delà de nous expliquer le dispositif du Rwanda en matière de sécurité sanitaire nationale, quels sont vos engagements et qu'est-ce que vous faites en termes de collaboration pour aider les autres pays de l'Afrique à être aussi performants que vous en matière de sécurité sanitaire?
Merci beaucoup, professeur Meda. Merci pour cette opportunité de pouvoir partager l'expérience de nos différents pays. Permettez-moi de m'exprimer en anglais. I'd like to thank everyone for sharing experiences here, and I think by learning from each other is the best way we can able to achieve this agenda that we're talking for Africa that we want. Perhaps let me just use the So for Rwanda, what we do is just again sharing experiences, learning from others, and trying to learn some of the best practices that happen here and there. But I want to speak specifically on this issue of global health security, because we really believe that it fits within functioning systems. You might want to start from a governance perspective and leadership perspective, but if you want to trickle it down to a specific sector, it has to be within a functioning health system. So 30 years ago, Rwanda was on the brink of collapse, started by rebuilding its health system. At the time, life expectancy was around 40 years of life expectancy. HIV, TB, malaria were the biggest killers. Maternal-child health metrics were really bad. So we started by just building the public health system. Fast forward, right now, I would say that in the last 30 years, we've gained a life expectancy of 30 years, reduced maternal mortality by 3/4, infant mortality by 2/3, HIV achieving the 95 targets, diseases. I'm saying this because by building that system, you're training people, you're putting in place the infrastructure, you're putting in systems that talk to each other within institutions, but across institutions as well. And as a result of that, I think you're able to respond to any shock that might come to you. And that's where maybe we can link it to COVID. When COVID hit, I would say the network of community health workers that we have across the country that have helped us achieve these gains. One example I can give is that 70% of cases of malaria in Rwanda are treated at the level of community by community health workers. And we've seen a decline of more than 85% in incidence, but as well as mortality in malaria. The same system that we use to tackle malaria is the same system we use to tackle COVID. One was communication. The people that are closest to the people, to convey these messages of prevention, of how do you behave, what are some of the things that you can do to prevent. The message was spread in a second across the country. Secondly was investment in research to understand the biology of the disease. SARS-CoV-2 hit, we worked with partners to understand its virulence, if you will. So we started sequencing with our other colleagues to understand really and to link it to the clinical characteristics that we had in our population. How is this disease affecting our population? What are the complications? And we quickly realized that maybe the virulence was not the same that was described in other parts of the world. So what do you do in terms of response? Do you send all your patients into wards in the hospitals where you have other patients maybe that have other comorbidities, and as we knew that if you have comorbidities you might risk to complicate that. So we quickly established what we called home-based care, assess with community health workers and keep the patients at home but following them closely. The third point I want to make is in terms of what did we lack at that time and how can we learn from it to strengthen our system. The prevention part of it, or at least for SARS-CoV-2, as we're using this example here, the viruses that cause COVID-19, was we lacked the vaccine for it. And there's been a debate in Africa to say, oh, maybe Africa had also a lot of cases of vaccine hesitancy. I think it's a false debate, but we've also, colleagues have demonstrated that it's actually a false debate. Actually, a paper by John showed that there was not an issue of vaccine hesitancy, but we had an issue of vaccine inaccessibility, if I may call it that way. But because of the trust that you build with your community, as soon as the vaccine was available, having mobilized the population, knowing the same country that supported them by dealing with HIV, they saw it firsthand from their relatives, conveying this message that this technology, this medication, this vaccine will help you. Quickly, as soon as we got the vaccine, we were able to roll out within less than a year, reaching close to 60% of coverage, and now we are at about 90% of coverage for double dose. So I really want to emphasize on the role of the connection between the leadership and the communities, building on existing systems, keeping up with what the science is showing, and investing in manufacturing. As a result of that, we've recently launched in Kigali the first mRNA-based vaccine plant with a partnership with BioNTech and other colleagues. And there's a reason behind that is just, again, as I said, to keep up with the science that's behind it. mRNA is proving to be the most efficient type of science that you can use for many diseases. You know that Africa is facing a double burden, an unofficial danger of infectious disease, but an emerging one of non-communicable diseases, including cancer. So we're also thinking, dealing with these infectious diseases, but also trying to see how can we invest in the therapeutics for our aging population, that actually some of them have the double burden. You have it, but also other comorbidities, to try and keep the people safe. We approach it in that health system level, and that's why we think, or we can define global health security, and we're always eager to learn from each other and to see how we can move the needle further and improve our health systems collectively. Thank you very much.
Merci beaucoup au Dr Boutera. À travers le partenariat, le Rwanda commence la fabrication de vaccins et je pense que ces vaccins seront pour le Rwanda et l'Afrique et le monde. Le Rwanda aussi est l'exemple de ce que la confiance entre la communauté et les services publics peuvent apporter dans une meilleure réaction, une meilleure solution face aux urgences de santé publique. Et il a bien expliqué comment les agents de santé à base communautaire ont vraiment été instrumentaux pour accélérer la vaccination universelle contre le Covid-19 au Rwanda. Et merci beaucoup, Dr. Boutera. Now let's turn to our friend from Libya. I think in May I was in Libya with a delegation of African CDC, and we were discussing how African CDC can support Libya to be some kind of also supporter in North Africa, because Libya has perhaps the most ancient CDC in this part of Africa. And rapidly after this mission, Libya was confronted by a flooding, I think, emergency. And perhaps you want to share how you manage to address this emergency, how you think Africa CDC, African Union were with you in this event, and how you can do more when this kind of emergency appears. Thank you, Dr. Syed, Minister of Health in Libya.
Thank you, Professor Meda. Good morning. I hope next time we speak in Fulani, Arabic, Hausa, or Swahili, because my French is not that good. So English is good for you, okay? We start from the end.
It's possible to speak in Arabic.
I can speak in Arabic?
Yes, it's possible.
Oh, okay, we speak in English. That's no problem. At the time of this flooding time, after your visit to Libya, it was a chance to examine the capacity of African Union to respond to state member and very African member of the IU, and CDC as the public health structure of the African Union. Actually, the response was to send three missions, but the intervention was, I don't know why, but was below the expectation from. So this arises a question. What's the need for a structured planned process or action plan to intervene in which kind of public health emergency? This because we didn't find. Sometimes we find, for example, because our country is a big country, faced civil conflict for more than 13 years now. And these years, a lot of partners come to help, thanks to them, but we didn't find that impact on public health. Maybe the condition went worse in our country. So this partnership, we need to be more structured, more organized, who intervene where. For example, at the week of the flood, this is my personal experience, we was arranging to make something to help our brothers in Morocco, because there was earthquake. While we are preparing ourselves, and then we will start to ask our brothers in Morocco what we do, we find ourselves seeking the help of our brothers from Morocco at the same week. The intervention was to work with, thank Allah that we have arms of Ministry of Health, the Libya CDC, NCDC of Libya, which is 40 years old institution, 33 years old with this name. We have two emergency apparatus and supply apparatus. We make work group with ministerial and multi-sectorial emergency and response task force like our brothers in Zambia did. After that, we start intervening because the effect not mainly was evacuation of people, providing shelter, then thinking about water contamination, thinking about some any infectious disease, thinking about supplying the drugs for the because people were with no houses, the drugs of non-communicable diseases and chronic disease control. At the first, second, three, we pass very smoothly with help with our friends from many countries in the globe, from South Africa to Russia to United States to Brazil. We find people from wherever to China was with us, including African and Arab states in solo intervention, not a collective intervention like this. I have three. I have three issues I want to speak about regarding the public health, the health security. We have a problem in preventive medicine, very big problem. We have very big problem, and we are thinking about in multi-sectorial intervention, because the primary health care means water sanitation, means food and nutrition, means many things, means health education, and means preventing the risk factors like salt, like sugar, like something. So in the preventive medicine, the preventive measures toward the infectious disease, toward the non-communicable disease, toward the neglected disease. These are the NTDs. This is the first challenge that we are facing. Challenge number two, we are working, making master plan on 2 million kilometers with a small population, lack of human resources, with inaccurate data in assessing and deciding. We are trying to make a national health number. We're trying to make a drug tracking. We're trying to make a human resources database. We are trying now, we are working on, not trying, actually the word was not correct, to work in a database of equipment, machines, labs, to start strengthening these parts of the system. The main problem in Libya, in my state, is the governing and leadership. The capacity of healthcare leader, and we have good framework of law and law system in Libya. We have a health system. We have two health law, and we have two laws regarding the drug security. We have one law for medical liability, and we have one law for health insurance. This framework, but the fragmentation of health system, and it is unfortunately our partners won't work all the time on to support this fragmentation, not to prevent. As you know, the health system need to work as a machine together with all components and all pillars of the health system, and this fragmentation distract the limited resources for healthcare, the human resources, and affect the health delivery. This, in brief, my intervention. I hope that we change the culture and the expectation of the people from the health system. Thank you.
Thank you. Thank you, Dr. Saed. Libya is what we call a country in transition, or a fragile country, but within this system, Libya is engaged to collaborate with other countries, engaged to collaborate with Africa CDC, but need more commitment from Africa CDC, Africa Union, to problem of Libya. And during the flood period, perhaps Libya didn't really see what the support of Africa Union was for their country. And this is something you need to know to see how we can better collaborate with Libya and North Africa. Nous avons beaucoup de contraintes de temps. Et les organisateurs ont demandé, bien que j'avais encore beaucoup de questions, je voulais que les ministres partagent les premières expériences d'utilisation des instruments mondiaux pour améliorer la sécurité sanitaire, tels que le Pandemic Fund. Je voulais que les ministres échangent, donnent leur expérience sur le partenariat, l'action commune OMS, Africa CDC sur la réponse aux épidémies, mais à cause du manque de temps, nous allons arrêter là et permettre aux ministres d'échanger pendant le déjeuner ou après sur toutes ces questions pour partager leur expérience. Et John est toujours là pour voir comment au niveau international, beaucoup de partenariats et de soutien peuvent aider l'Afrique à améliorer l'état de sa sécurité sanitaire. Je vous demanderai d'applaudir avec moi l'ensemble des panélistes. Please clap for all the panelists here. And, en tout cas, grand merci pour votre contribution et aux organisateurs pour la suite du programme. Merci beaucoup.
Thank you and merci, obrigado. We apologize because we have 4 panels, so we are giving 1 hour to each panel. so we could not get a chance to allow too many questions. Long ago, before I got gray hair, I was a child growing up in Uganda. My mother was a nurse working in a hospital, and I lived in a hospital. And the diseases she would talk about malaria, she would talk about cholera, she would talk about typhoid. We have heard from the previous panel, cholera is still a problem in Africa. Dr. John talked about malaria still being a major problem. Of course, HIV was not around in the 60s. And today we have been talking about a whole of government as well as a whole of society approach. The next panel is going to discuss what does it take to eliminate a disease like cholera, a disease like polio. But for the purposes of today, we are going to look at 4 diseases. I think it's back. No. Just 1 second while the system gets back. Yes, we're back. Thank you. For this panel, we are going to be focusing on 4 diseases: hepatitis C, malaria, HIV, and neglected tropical diseases, which is, of course, a lot of diseases. And it is our pleasure and privilege to have Ms. Joy Pumapi, former Minister of Botswana and Executive Secretary for ALMA, to chair this session. So I would like to invite her to come to the panel. There is no better person who can chair a session on disease elimination than Joy, who has been a Minister of Health herself, but who now heads up an organization whose mission, among many other missions, is to eliminate malaria from several countries in this continent. Ms. Joy Pumapi. Thank you.
Yes. Thank you so much. Your Excellencies, Honorable Ministers, distinguished delegates, all protocols observed. I'm absolutely delighted to have this opportunity, and I thank our Ministerial Executive Leadership Program for giving me this chance to moderate this distinguished panel. It now gives me a great pleasure to invite the members of this panel, which is going to be focusing on how you design a whole of government, whole of society strategy in the disease elimination process. It's a massive challenge. So like we always say on the African continent, if you want to walk far, you must walk together. So the distinguished panelists who are going to tell us about how they are designing, or they did design, a whole of government, whole of society strategy, what the requirements were, the effective ways to engage with different members of society, with governments, the challenges that they are facing. is a distinguished panel of His Excellency, Professor Khaled Abdullah Ghaffar, Minister of Health and Population of Egypt. Your Excellency, if you can come and join. Is the Honorable Minister of Egypt with us? It looks like we have lost some of our ministers. While we are waiting for the Honorable Minister of Egypt, I saw the Minister of the DRC walking out, so I won't call him either. We also have Her Excellency, Dr. Philomena Gonçalves, the Minister of Health of Cape Verde. You are welcome to the podium, ma'am. We are absolutely delighted to have this minister. She has just effectively eliminated malaria. Thank you. Thank you, Minister. And she's going to share with us the important lessons of how to do it. We have the Honorable Mduduzi Matebula, Minister of Health of Eswatini. Is the Minister of Health of Eswatini here? Eswatini is one of the countries that is effectively combating HIV/AIDS. Lots of success stories to share. You are welcome, Honorable Minister. I saw His Excellency Minister Kamba walking away. So if members of the CDC could please try and get us the two ministers back. And in the meantime, we'll start with the two ministers that we have before us. So, honorable ministers, you have got important lessons to share. But I would like to start off by giving you just 5 to 6 minutes for you to actually give us a summary of what is actually required. How do you get to the elimination process? And later on, I would like to ask you some probing questions, that can really get us, for you to share the lessons even better. So I will start with you, Honorable Minister Gonçalves. I know you'll be speaking in Portuguese, so I will probably need some translation myself. Over to you, Honorable Minister. So how did you achieve this magnificent feat? Yes. Do you want to come here?
Muito obrigada. Bom dia a todos. Excelências, é com profundo prazer e honra que hoje me apresento perante vós, representando Cabo Verde, um país que se orgulha de um feito histórico, a certificação pela Organização Mundial de Saúde como território livre do paludismo no dia 12 de janeiro de 2024. Este marco não só reflete o firme compromisso e a liderança exemplar do governo de Cabo Verde, mas, acima de tudo, do povo cabo-verdiano. Mas também permitam-me destacar o impacto significativo da colaboração multissectorial na promoção da saúde pública. A nossa jornada até este ponto foi marcada por desafios notáveis, particularmente no ano de 2017, deparamos com o surto de paludismo. Foi um período que exigiu muita mobilização, estratégia integrada, abrangendo não só o setor da saúde, mas o princípio de saúde em todos os setores, em todas as políticas. Envolveu, nomeadamente, os Ministérios da Cultura, da Educação, das Finanças, do Turismo. Elaboramos um plano estratégico holístico, sob a égide de uma liderança resiliente e o engajamento de múltiplos setores da sociedade. Isso nos permitiu vencer a adversidade. Desde janeiro de 2018, que testemunhamos o último caso de transmissão autóctone de paludismo em Cabo Verde. Este marco não apenas evidencia a eficácia das nossas políticas e estratégias, mas também impulsionou o país a iniciar o processo de certificação junto da OMS, que aconteceu em 2021. Com orgulho, reconhecemos que, passados 6 anos, eis que conseguimos obter a certificação de país livre de paludismo. Uma vitória que atesta a força da nossa abordagem colaborativa e o compromisso coletivo na erradicação desta enfermidade. Este sucesso exemplifica a capacidade de Cabo Verde responder prontamente a desafios complexos, guiado por uma visão estratégica de longo prazo. Unidade, cooperação, determinação, revelados neste percurso, sublinham a essência de um esforço conjunto e coordenação crucial para alcançar metas significativas em saúde pública. A erradicação do paludismo é, assim, uma demonstração eloquente de que, com a sinergia entre os diferentes setores e a participação ativa da comunidade, é possível superar adversidades e alcançar objetivos de saúde pública de grande impacto. Permitam-me fazer aqui uma pequena contextualização, que o paludismo é uma doença que por séculos devastou comunidades em todo o mundo. Exige uma abordagem complexa e multifacetada para sua erradicação. Em Cabo Verde, compreendemos cedo que a luta contra esta doença transcendia as capacidades exclusivas do setor da saúde, demandando uma estratégia abrangente, envolvendo diversos setores governamentais e a sociedade civil. Destaco aqui a importância da atuação multissectorial, que espelha numa planificação e implementação integrados, na gestão de recursos compartilhados, para podermos pôr a tónica e dar prioridade à eficiência e eficácia e, com isso, caminharmos para a sustentabilidade da saúde. Também o fortalecimento da vigilância e respostas rápidas. Ainda tivemos a oportunidade de ter as boas práticas e aprender boas lições. A nossa experiência revelou várias boas práticas essenciais para a erradicação do paludismo, especialmente num país arquipelágico como é Cabo Verde, onde os desafios são multiplicados por 10, porque somos 10 ilhas, pela dispersão geográfica. Mas isso não impediu que conseguíssemos um engajamento comunitário e educacional. A mobilização e participação ativa das comunidades foram cruciais. Uma estratégia de comunicação aperfeiçoada em função da especificidade da localidade. Uma coordenação estrita com os líderes comunitários. A educação e a sensibilização utilizando meios simples de comunicação, nomeadamente rádios comunitários. Mas também as entidades religiosas foram cruciais na educação, na sensibilização das populações. Também a integração de tecnologias de inovação, porque, por sermos 10 ilhas, por o transporte entre as ilhas representar um desafio enorme para o nosso país, fomos obrigados a utilizar desde cedo as novas tecnologias no setor da saúde. Isso facilitou, e de que maneira, a comunicação. Nós temos uma boa cobertura em termos de utilização das novas tecnologias no seio das nossas populações, mesmo as mais distantes. Isso facilitou e muito a comunicação. Mas quero pôr a tónica também nas parcerias estratégicas. Parcerias com parceiros locais, regionais, nacionais, internacionais. E aproveito aqui para agradecer a todos os parceiros, sem exceção, a todos os países que, a nível bilateral, mas também, permitam-me, agradecer a cada cabo-verdiano. Nós não chegamos a 500 mil, mas cada um teve um papel crucial para que conseguíssemos este ganho incomensurável. Também fomos obrigados a fazer adaptação e fomos obrigados a sermos flexíveis. A capacidade de adaptar estratégias em respostas a mudanças epidemiológicas e ambientais foi também fundamental. Por sermos um país arquipelágico, somos dos mais fastigados em termos das mudanças climáticas e das suas consequências. Quer dizer que também os nossos vetores acompanham as mudanças. Nós fomos obrigados a estudar os comportamentos, as mutações dos mosquitos, fomos obrigados a combater mosquito a mosquito, cada mosquito com a sua especificidade. Mas valeu a pena porque conseguimos. Em conclusão, minhas senhoras e meus senhores, a erradicação do paludismo em Cabo Verde representa uma conquista mundial, representa uma conquista regional, uma conquista continental. Permitam-me dizer que nós estamos aqui no nosso maravilhoso continente. De nada vale Cabo Verde ter a certificação de país livre de paludismo para que todos os dias termos nossos irmãos a morrerem por causa do paludismo. Quero dizer com isso que, com toda humildade, Cabo Verde tem toda a disponibilidade em partilhar a sua experiência. Cada país, cada governo irá avaliar lá onde entender que poderá aproveitar para implementar, para juntos vencermos este desafio, estaremos de braços abertos. Também aproveito aqui para deixar toda a disponibilidade do governo de Cabo Verde, do povo de Cabo Verde, em receber pessoal técnico, cientistas, políticos, governos, para caso a caso mostrarmos em loco tudo aquilo que nós fizemos para conseguirmos este feito. Com isso, resta-me dizer, caros irmãos, é possível, sim, vencer paludismo. É possível, sim, vencer os desafios de saúde pública. E é possível, sim, fazer do específico, do micro para o macro. Cabo Verde é um país microscópico ao nível do continente. Representamos talvez uma gota no meio do oceano, mas é gota a gota que juntos conseguiremos vencer os desafios de saúde pública no nosso continente. É gota a gota que conseguiremos a cada dia salvar, ainda que seja uma única vida, por causa de malária, e com isso estaremos a contribuir para que a humanidade seja mais saudável, para que a humanidade tenha saúde. Saúde no sentido de viver com qualidade de vida, de viver sem doenças, de viver feliz, sobretudo no nosso continente, que é um continente que foi feito milimetricamente para que o seu povo seja feliz. Muito obrigada pela vossa atenção.
Thank you very much, Honorable Minister. I let you speak for a long time because, you know, this is an amazing feat. You are the third country on the continent after, excuse me, I need water, after Mauritius and Algeria to, to be declared malaria-free. So, thank you, Minister. I beg your pardon. I think there's too much wind blowing. I would like to welcome the Honorable Minister of the DRC, Honorable Minister Dr. Roger Kamba. You are welcome. And we look forward to you sharing with us your NTD strategy, because DRC does have a lot of NTD challenges. And we know that you have made some successes, but you still need to go towards elimination. Honorable Matsebula, I would like to give you 5 minutes because I would like to do another round of questions. So give you 5 minutes just to give us, share with us how you got to 95 with HIV. I don't know whether your mic is working or whether you prefer to come here. Thank you.
Moderator, honorable colleagues, a good day. I'm excited to be requested to say something about Eswatini's experience in eliminating HIV/AIDS. Eswatini is among the first countries to achieve the 1995 UN AIDS targets earlier than anticipated. And I will highlight about 5 success factors. One being a strong political will. The declaration by His Majesty the King that HIV/AIDS inzaba yethu sonke, which basically means HIV is everybody's problem, including a rallying cry at the UN summit, set the tone. An HIV/AIDS response pitched at the highest level of government which is the PM's office, responsible for nature, which is the National Emergency Response Council on HIV/AIDS, established through an act of parliament to oversee, coordinate, and facilitate the multi-sectoral approach to HIV/AIDS response that ensured that all sectors of government were involved. Identifying a budget for procuring ARVs, the most important commodity, was also another factor. Number two is the evidence-based policies, which include early adoption of evidence of test and treat in 2016. Eswatini was quick to adopt the change in treatment guidelines following evidence of effectiveness of the ART, if given soon after HIV diagnosis. Conducting regular population studies such as the Swaziland HIV Impact Measurement Survey, which provided the needed evidence to change policies and identifying those vulnerable groups such as young women from 19 to 25 years who continue to have high infection rates. Number three is the community involvement. Due to the multi-sectoral approach in HIV/AIDS response, the community leaders such as chiefs were also sensitized. Other community members involved in the response included traditional healers, community workers, etc. The populations were involved in the HIV/AIDS response include commercial sex workers, prisoners, gay men and young women, which addressed equity challenges. 4, the primary healthcare service delivery models that include decentralization of services. Eswatini ensured that HIV services were decentralized to the primary level, healthcare level, which are clinics closer to where communities live in the rural areas. This was supported by a task sharing of ART from doctors to nurses. Investing in diagnostics that could be rolled out to lower level health facilities. 5, adaptability during pandemics, such as COVID-19. During COVID-19, the country's health system showed adaptability to the lockdowns that prevented access to healthcare by people living with HIV. Services were brought even closer to the people through provision of 3 to 6 months prescriptions for some clients, establishing a toll-free number 1212 for clients to call and make an appointment to receive their ARTs at certain community spots. Deployment of kiosks for ARV refills and allowing clients to know where to collect them. I will also highlight a few challenges. Swaziland HIV Impact Measurement Surveys has provided an evidence of where to focus towards ending HIV/AIDS as a public health threat in Eswatini. And I will also highlight about 5. 1, close the remaining population-specific treatment groups, such as the adolescent and young women, key populations, through rolling out of HIV diagnostics, such as self-test kits at community level. 2, Further reduce the number of new infections of HIV through rolling out the pre-exposure prophylaxis, including adopting the new PrEP methods such as acting injectables. 3, fighting the scourge of gender-based violence, which is an impediment to reducing new HIV infections. GBV is associated with gender inequality, which limits full access to HIV services. We will recall that fear or act of harm reduces ability to negotiate condom use. Controlling partners may not allow partner to seek health care, including testing and treatment. Number 4, integration of HIV services. Which other services such as TB, NCDs, hepatitis, to ensure sustainability of the interventions. 5, discussions on sustainability of HIV response, looking at transitioning of some donor-supported activities, such as monitoring of staff providing HIV services at facility level. I would like to give a summary of the lessons learned. I will also highlight about 5. Just in summary, strong political commitment is critical. All society groups ensures acceptance and commitment to efforts. Higher level of coordination ensures collaboration. Community engagements and public awareness through different platforms. Include key populations when designing prevention and treatment programs for a better uptake and outcome. And maybe last is that domestic funding is necessary for sustainability of health programs. I'll be making a mistake not to thank our who have played a pivotal role in the fight. They've done a good job, and we hope they will journey with us as we fight actions and sustaining the gains. Siyabonga. Thank you.
Siyabonga Bekunene. Thank you so much, Honorable Minister. I'm going to ask you a little bit later on about sort of the monitoring and evaluation. So if you can give us a little bit on that. And Honorable Minister, I'm going to be asking you about how you're going to sustain the success. But before we go there, can we have the Honorable Minister come and share us your strategy on the elimination of NTDs?
Merci beaucoup. Je vais parler en français. Les maladies ont un vrai poids dans le système de la République démocratique du Congo. Nous avons malheureusement énormément de zones de santé de notre pays qui sont touchées par les maladies tropicales négligées. Nous avons en général, le pays a 516 zones de santé et nous avons 484 zones de santé qui sont touchées par les maladies tropicales négligées. Malheureusement, elles touchent les populations les plus faibles, les plus pauvres et celles qui ont le plus de difficultés à accéder au système de santé, qui ont des difficultés à accéder à l'eau. Et ces maladies-là ont la caractéristique de malheureusement défigurer les gens, de rendre aveugles, d'handicaper et donc en fait finalement d'aggraver au niveau social les relations parce que souvent ça entraîne des difficultés d'accéder à l'école pour les enfants, ça entraîne des difficultés de socialisation avec les autres membres de la famille. Et donc ça isole davantage les malades. Donc la RDC a un plan pour répondre aux maladies tropicales négligées, une des premières choses qu'on a fait, c'est la cartographie de ces maladies-là. On en a quasiment toutes. Il y en a pour lesquelles la cartographie n'est pas finie, comme le trachome, par exemple. Mais pour l'onchocercose, leishmaniose et puis géohelminthiase, la cartographie, elle est faite. Sauf que c'est des maladies, pour l'instant, dans notre pays, qui sont souvent prises en charge seulement par la communauté internationale, au niveau financier. Donc nous avons un plan qui va de 2021 à 2025 pour pouvoir finir la cartographie pour certaines, éradiquer celles que nous pouvons éradiquer, notamment en faisant plusieurs choses. La première chose qu'on fait, c'est la chimiothérapie préventive. Et celle-là, elle permet en fait d'accéder à des masses plus importantes et donc à toucher le plus grand nombre de personnes. La deuxième chose, c'est de lutter contre les complications, parce que ces malades-là ont souvent beaucoup d'autres complications. La troisième chose, c'est effectivement lutter contre les vecteurs de ces maladies. La quatrième chose, nous essayons aussi de lutter contre les zoonoses. Comme vous savez, nous avons des grandes forêts en Afrique, notamment en RDC, et nous avons effectivement beaucoup de maladies qui sont des zoonoses. Et donc, c'est un vrai problème, c'est un vrai challenge pour notre pays. Et le cinquième point au niveau de la réponse stratégique, c'est le WASH. Il faut quand même que ces personnes-là puissent accéder à l'hygiène et à l'eau. Donc ça fait beaucoup de choses, mais la RDC a déjà eu beaucoup de succès, notamment au niveau de la réduction d'un certain nombre de prévalences de ces maladies-là, mais aussi de l'interruption de la transmission. Comme j'ai dit au début, nous avons cartographié, et ça c'est une très très bonne chose, mais il nous manque encore un certain nombre de capacités, notamment, comme j'ai dit, pour le trachome, que nous n'avons pas encore fini de cartographier. Et nous devons d'ailleurs aussi cartographier encore, par exemple, pour l'onchocercose. Alors, comme je disais, c'est vraiment des maladies qui sont souvent prises en charge au niveau financier par la communauté internationale, ce qui fait que quand il y a eu Covid et que malheureusement beaucoup de fonds ont été déviés, on s'est retrouvé avec beaucoup de programmes qui ont été arrêtés quasiment, voire parfois même annulés. Cependant, nous avons l'obligation en tant que pays de participer de plus en plus au financement. Et c'est pour cela que nous voulons inscrire la prise en charge des maladies tropicales négligées dans le cadre général que nous sommes en train d'instaurer, qui est celui de la couverture santé universelle, avec une stratégie de relais communautaire pour la surveillance et pour aussi la distribution effectivement de la chimiothérapie préventive. Les besoins que nous avons estimés pour le plan global s'élèvent autour de 112 millions de dollars, mais juste pour l'année 2024, nous sommes autour de 16 millions de dollars pour nos maladies tropicales négligées. Donc en gros, pour nous, c'est un gros poids qui est reparti quasiment dans tout le pays, dans les 26 provinces, mais spécifiquement dans 484 zones de santé sur nos 516. Donc c'est vraiment très généralisé. Et malheureusement, encore une fois, c'est des personnes qui ont des difficultés à accéder aux soins de santé de manière générale et au niveau de l'accès à l'eau, malheureusement. Donc nous essayons pour l'instant de mobiliser des ressources pour pouvoir, au moins pour cette année, finir la cartographie et relancer la chimiothérapie préventive, mais nous essayons aussi d'inscrire le plan global pour que, à terme, nous puissions éradiquer la plupart de nos maladies tropicales négligées. Je vous remercie.
Thank you so much, Honorable Minister. And I thank you for being brief. We have just a few minutes for one question each. And the question, I'll ask you a different question, each of you, but one question I want all of you to answer. Now, the one question that I want all of you to answer, that is extremely important, is how do you balance? Because there are so many competing disease priorities, so many. So it's not just those diseases that need to be eliminated. Africa is currently plagued by NCDs. So there are so many competing priorities. How do you prioritize? That is the question. In addition to that, Honorable Minister, you have eliminated malaria. Now, how are you going to sustain this? Can you answer those two questions? And I'm hoping your mic is working.
Muito obrigada. De facto, quando os desafios são muitos, escolher é um bocado difícil. Mas nós temos que começar por algum ponto. E temos que avaliar, em função dos desafios que nós temos nas mãos, dos recursos que nós temos, no momento em que vamos decidir, qual é que será a prioridade ou qual é que representará o menor caminho para chegarmos ao sucesso. É o que se passou conosco a quando de certificação de país livre de paludismo. Tivemos um foco em 2017, fomos obrigados a implementar estratégias muito bem planeadas e executadas, a fazer investimentos, a envolver todos os parceiros. E rapidamente conseguimos, de facto, eliminar. E chegamos à conclusão que sim, afinal é possível. O importante é não baixarmos a guarda. E, porque fomos capazes de eliminar o paludismo com aquilo que nós tínhamos empregue nesse surto, aprendemos uma boa lição. Não obstante a existência de muitos desafios, nós trabalhamos de uma forma holística, temos que avaliar em qual dos desafios estamos melhor preparados ou teremos maiores hipóteses de sucessos, mas sem descurar os outros desafios. Para a manutenção da certificação de Cabo Verde, país livre de paludismo. De facto, o trabalho começou no minuto seguinte à entrega de certificação, no dia 12 de janeiro, porque mais de conseguir a certificação e a sua manutenção. Trabalhamos num plano estratégico muito ambicioso, um plano estratégico onde nós temos a planificação de todas as atuações das lições apreendidas, mas fomos muito mais além. Por quê? Se nós tivemos o sucesso durante os 6 anos até a certificação sem termos um caso autóctone, nós temos casos importados. Nós temos ligações diárias com países que têm malária de forma endémica. Quer dizer que nós temos que estar sempre vigilantes. Quer dizer que nós temos que aplicar protocolos de uma rigorosa para garantirmos e aplicar-se para termos casos autóctones. E há situações que, só vendo, para as pessoas perceberem aquilo que nós fazemos quando nós detectamos um caso importado. Temos um protocolo muito cerrado em que todo e qualquer viajante é monitorizado durante 2 semanas. Todos os dias as pessoas são chamadas, são acompanhadas para saber se não tem nenhum sintoma. E havendo um sintoma, há um protocolo específico num raio da residência dessa pessoa ou do local onde a pessoa esteve, onde se fazem, nomeadamente, as pulverizações para evitar que tenhamos casos, mas continuaremos a investir. Muito obrigada.
Thank you so much, Honorable Minister. Very solid response. I think lots of good lessons that can be picked up there on how to build sustainability. Now, Honorable Minister, you talked about, you know, how you got to 95, 95, 95. I mean, we know that that's sort of like 3 indicators of success. Is there any indicator that you feel is particularly important for tracking elimination?
Thank you. Monitoring trends is critical. Like following the rate of prevalence in maybe age groups, gender, key population, and the level of tolerance, because then it guides you in terms of pressure points and where to channel your resources for a better outcome. I would summarize it like that.
And then how do you, Honorable Minister, how do you prioritize? You know, you want to eliminate HIV, but you've got so many competing priorities. So how do you prioritize?
It's a tough one. With limited resources, it's not easy to prioritize, but you see where the highest rate of prevalence is. And then you know your pressure points, and then you try to channel your resources to first deal with your pressure points before scattering your resources all over.
Thank you, Honorable Minister. Honorable Minister, you enumerated numerous challenges that you are facing, and I know those are not the only ones. Can you speak a little bit more about how you actually prioritize the limited resources, but also say a little bit about partner engagement in DRC? How solid is it?
Ben, merci beaucoup. Alors, c'est vrai que pour faire des priorités, quand on est dans un pays comme la RDC, c'est très difficile. Mais quand même, on prend un certain nombre de critères qui nous permettent de décider. Un des premiers critères, c'est vraiment quel est le poids de la mortalité dans les maladies les plus courantes. Et quand on regarde ce poids-là, on voit encore que les maladies infectieuses, on voit encore que les maladies de la mère et de l'enfant sont vraiment le premier poids dans la mortalité. Donc, la première priorité qu'on se donne, c'est de dire comment est-ce qu'on essaie de rallonger l'espérance de vie en agissant sur les facteurs les plus déterminants de cette espérance de vie. Deuxièmement, la RDC, c'est un pays où il y a énormément d'épidémies qui naissent parfois là, en RDC. Actuellement, nous sommes par exemple confrontés à la variole du singe et on voit que nous devons aussi éviter que ces maladies épidémiques puissent prendre de l'ampleur, puissent menacer tout le système. Donc d'une part, on lutte pour diminuer la mortalité des maladies les plus importantes, mais d'autre part, on essaie de prévenir celles qui peuvent dégénérer et causer encore plus de dégâts. Mais troisièmement, comme je l'ai dit, c'est comment est-ce qu'on renforce le système de santé à la base. Parce que finalement, quand on a renforcé le système de santé à la base, on arrive à répondre à la plupart de ces maladies. Donc pour prioriser, on essaie de prendre un certain nombre de critères qui nous permettent de faire des choix en sachant que nous avons des ressources limitées. Maintenant, par rapport aux partenaires, il faut dire que quand on regarde les ressources que l'État congolais met dans le système de santé, les ressources qui sont dépensées par les familles, parce que les familles restent quand même le premier payeur en fait du système de santé, eh bien, les partenaires amènent énormément d'argent. En RDC, je pense que nous tournons autour de 42% du budget qui est pris en charge par les partenaires. Donc, c'est vraiment un appui très solide et un appui qui n'est pas seulement financier, qui est aussi un appui qui nous accompagne dans la plupart des choix que nous faisons. Je citerai particulièrement les très grandes organisations comme la Banque mondiale, le Fonds mondial, Bill and Melinda Gates Foundation, tous ces partenaires interviennent et parfois ils anticipent. Comme le département d'État, la Maison-Blanche par exemple, ils sont en train d'anticiper sur le monkeypox. Donc nous avons un très bon partenariat et nous pensons que, effectivement, au-delà de l'augmentation de nos propres ressources, le soutien des partenaires est encore très important pour nous actuellement.
Thank you so much, honorable ministers. And as it has been said, our time is very limited, so we are coming to the end of this panel discussion. I believe since this is a leadership program, Egypt owes the program to share its lessons from being declared. It's very, very close. It has been given, I think, something like gold star status by WHO, which means it's on the verge of eliminating hepatitis C. And I believe they should share this. So I hope the MELP organizers will ask Egypt to actually share its best practices with the other ministers. But we have had very, very erudite sharing of experience from the panel. They have given us sectoral collaboration, how they did it, resource allocation and funding. Difficult as it is, they managed to find a way. Monitoring and evaluation, where it is critical, the lessons learned, best practices, but leadership, but also surveillance and having effective systems in place, going down to community level. The lessons are numerous. Let's give a big hand to our honorable ministers, and thank you for sharing your experience. Thank you. Thank you, honorable minister. Much appreciated. Thank you so much.
Let's give a hand of applause again to our panel and moderator. I hope next year when we meet, we will have other countries to share their experience. We know that Togo has also successfully eliminated 4 neglected tropical diseases. So we are going to have one more panel before lunch. I have been assured that that when you are hungry, the food tastes better. So bear with us that we will be a little bit hungry, but by the time we eat in an hour's time, the food will taste better, and we will take a lunch break of an hour after the next panel. I want to invite to the panel Dr. Magda Robalo, former Minister of Health for Guinea-Bissau and serving as a senior MELP advisor, who is going to be moderating a session on maternal mortality and morbidity. And as we all know, this is an issue that continues to plague many of our countries, but I will allow Dr. Magda Robalo to speak to this topic, as well as to invite the speakers who are going to be contributing to this discussion. Let's give a hand to welcome Dr. Magda Robalo.
Thank you, Alex. Good afternoon, Your Excellencies, honorable ministers, and dignitaries in this room. I know it is a difficult task to be standing between you and lunch, but I know you'll bear with me. This is going to be a tough discussion. We have heard about eliminating diseases. We heard about achieving global health security. Maternal mortality is one such thing that I think we are all looking for eliminating and eradicating from the continent and from the world. So there are many lessons to be learned. Unfortunately, Africa continues to have the highest maternal mortality ratio in the world. 531 women out of 100,000 live births die every year due to complications related to pregnancy. 60% of the global maternal mortality is on this continent. If we don't reduce maternal mortality to the levels that are required by the SDGs, which is 70 per 100,000, the world will not achieve that particular SDG, which is under SDG 3, and that will be because particularly our continent. The priorities are many. We have just heard the ministers say that it's difficult to prevent mothers from dying because they are giving birth. I'm going to moderate a panel of 3 honorable ministers from Côte d'Ivoire, from Lesotho, plus an expert on human resources, which will also contribute to the discussion on how can we reduce maternal mortality. It is a panel that you'll see is an all-male panel, which is not a panel that ideally I would have, but it has been compensated because the next panel will have 3 women and just 1 man. So it is with great honor that I'd like now to invite His Excellency Dr. Pierre Dimba, Minister of Health from Côte d'Ivoire, to join us. A round of applause for him as he joins us. And we congratulate Côte d'Ivoire for winning the African Cup of Nations. A strong round of applause. His Excellency Dr. Selibe Mokoboroani, please forgive me if I didn't pronounce your name well. Minister of Health, Lesotho. Welcome. His Excellency Dr. Dereje Duguma, State Minister of Health, Ethiopia. Well taken. And Dr. Patrick Kadama, Executive Director for Africa Platform on Human Resources for Health. Please join us. A round of applause for them. Thank you so much for joining this important panel. And the first question I'm going to ask each one of you is similar, but I know you have different experiences to share with us. And I would also like to invite you to be short and concise so that we can have different iterations and then discuss several issues around maternal mortality in our continent, particularly in your own countries. I will start really with a question about what kind of challenges are you facing and to further reduce maternal mortality in your countries, and what successful priorities, interventions have you implemented to bring maternal mortality down from the very high levels that you still have in your respective countries? I'll start with DRC. Okay. But when you come here, speak from there. Is it on?
Merci. Honorables invités, vous savez que la question de la mortalité maternelle constitue une sérieuse préoccupation dans nos différents pays, une préoccupation de santé publique, et la Côte d'Ivoire n'est pas en reste. Même si nous devons reconnaître que ces dernières années, des efforts importants ont été menés pour réduire la mortalité maternelle de 35%, ce qui s'établit aujourd'hui donc à 385 décès maternels pour 100 000 naissances vivantes à partir de l'étude démographique que nous avons réalisée en 2021. Et la plupart de cette mortalité intervient dans nos établissements sanitaires, 86%, 10% pendant le transfert des parturientes de leur domicile vers les centres, et 4% donc, dans les communautés. Les principales causes donc, de cette mortalité se situent au niveau donc, de l'hémorragie. La Côte d'Ivoire est particulièrement affectée par l'anémie des femmes, et donc, ce qui fait que l'hémorragie postpartum donc, constitue la première cause de mortalité, suivie donc, des complications obstétriques. Et puis ensuite, il y a l'hypertension aussi qui est donc à la base des causes donc, de mortalité. Et lorsque nous regardons de façon détaillée, à partir des audits que nous réalisons sur les mortalités maternelles dans nos établissements, nous pensons que l'une des principales causes, c'est le retard de prise en charge du faible nombre donc, de spécialistes, de gynécologues qui ne sont pas suffisants. Donc au total, on a 270 spécialistes gynécologues dans tout le pays, mais regroupés à 70% dans la capitale, alors que la capitale n'a que 21% de la population. Ensuite, les sages-femmes qui sont déployées dans la plupart de nos centres de santé ont des difficultés pour prendre en charge les complications obstétricales. Et donc, ce qui fait que, effectivement, beaucoup de femmes donc, sont prises en charge tardivement, ne bénéficient pas des soins appropriés et donc peuvent en mourir. Nous avons également noté que dans beaucoup de nos centres de santé, les blocs opératoires nécessaires pour prendre en charge ces femmes n'étaient pas fonctionnels. Et donc, il fallait donc travailler à cela, sans compter que le sang, à un moment donné, était un problème. D'abord, il y avait l'insuffisance de sang, mais les prix étaient disparates et non accessibles à tous. Donc, et sans compter que les kits de césarienne et d'accouchement n'étaient pas disponibles. Alors, tous ces défis ont été adressés à travers un plan qui a été mis en place, une initiative prise, soutenue par les plus hautes autorités avec le chef de l'État. Et ce que nous avons pu faire, c'est d'abord de redéployer donc, le personnel de santé de la capitale vers les autres centres de santé de façon à équilibrer ces centres-là. Donc, les gynécologues non universitaires qui étaient pour la plupart dans nos CHU ont été redéployés donc, dans les différentes régions. Et nous avons organisé le pays en 10 pôles régionaux d'excellence sanitaire. Et donc, nous avons fait en sorte que dans chaque pôle, il y ait un minimum de gynécologues pour prendre en charge les complications. Nous avons également lancé donc, la formation pour le transfert donc, de tâches aux médecins généralistes. Et il y a eu, donc, avec un objectif de 240 à peu près sur 4 ans. Et la première vague de 25 gynécologues ont été formés et redéployés. En même temps que nous avons travaillé avec l'UFR des sciences médicales pour déployer donc, des universitaires de rang A pour permettre donc, de participer à la formation de ce personnel, mais y compris des internes et des généralistes, donc au niveau des différents pôles du pays, qui ont bénéficié également des investissements importants, que ce soit donc, au niveau du plateau technique, mais au niveau des labos et de l'imagerie. Cela nous a permis donc d'accroître de façon substantielle les capacités de prise en charge des patients. L'État a rendu gratuit non seulement la consultation prénatale, mais également tous les kits de césarienne, kits d'accouchement et la prise en charge des complications, en même temps que la planification familiale a été donc prise en charge et donc les produits de contraception donc, sont gratuits en Côte d'Ivoire. De 500 millions, nous sommes passés aujourd'hui à plus de 2 milliards chaque année et ça permet donc d'espacer les naissances et de permettre aux femmes donc, de pouvoir gérer leur grossesse et donc de pouvoir donc, éviter donc, la fragilité qui permet donc d'être à la base donc, des décès. Il y a eu également donc, un rapprochement des blocs opératoires par la construction, donc, surtout dans les zones où nous avons constaté que le taux de mortalité était le plus élevé, de blocs de services d'obstétrique, comprenant donc, des blocs avec tout le nécessaire pour que les femmes puissent être prises en charge rapidement. Et donc, il y a eu 62 centres qui ont été construits à travers tout le pays pour rapprocher donc, les blocs des parturientes et les prendre en charge. Aujourd'hui, donc, le montant total des investissements prévus d'ici 2025 pour réduire de façon drastique et tendre vers les 70 décès pour 100 000 naissances pour atteindre les ODD sont autour de 300 milliards mobilisés à partir des ressources domestiques, mais également donc appuyés par les partenaires au développement, dont la Banque mondiale et la BID, etc. Ce que nous avons également fait, c'est d'utiliser l'innovation pour pouvoir rapprocher là où les services, où les professionnels manquent des services. Notamment, donc, nous sommes en train de déployer tout un système informatique avec les SIH et la télémédecine pour que les sages-femmes puissent être accompagnées et guidées à distance, ainsi que les médecins généralistes à qui on délègue des tâches, donc elles puissent être accompagnées par les professionnels. Je pense que pour réussir vraiment la réduction de la mortalité maternelle, c'est une tâche importante qui doit être vraiment bien planifiée. Mais la planification, les objectifs nationaux doivent être déclinés dans chaque région sanitaire, puisqu'on a constaté que sur les 113 districts sanitaires, on compte 29 où le taux de mortalité est au-dessus de 100 décès pour 100 000 naissances de vivantes. Et nous travaillons spécifiquement sur ces districts, mais nous travaillons de façon générale à asseoir donc une politique nationale pour réduire donc le taux de mortalité maternelle. Et donc, c'est important qu'il y ait des échanges à travers le système qui a mis en place, qui permet aussi la formation à distance, mais également que les objectifs qu'on a fixés au niveau national ont été également déclinés au niveau de chaque région. Et avec l'appui des communautés, on développe un peu plus de redevabilité sur la prise en charge, mais également la promotion donc, de la santé de la mère et de l'enfant. Voilà les éléments que je voulais partager avec vous. Mais c'est sûr que c'est une action de longue haleine. Nous continuons de travailler et rendre disponible aussi bien le sang. Aujourd'hui, le sang est distribué à travers donc, des drones. Donc, ça rapproche plus le sang et nous sommes autosuffisants en sang grâce à la mesure prise par le gouvernement de réduire non seulement le prix de cession du sang à 3 000 francs, aussi bien dans le privé que dans le public, mais d'investir pour que nous puissions produire suffisamment de sang, notamment en mettant en place donc, des centres de technicage de sang un peu partout dans les pôles. Je vous remercie.
Merci beaucoup, Monsieur le ministre. Je vais juste vous poser une question de suivi. Vous avez parlé de la gratuité des soins, du sang qui est disponibilisé par des drones, de la télémédecine, du redéploiement du personnel de santé. Avec tout cet investissement, la formation, le financement, quel est votre objectif de réduction de la mortalité maternelle en Côte d'Ivoire dans combien de temps?
Grâce à ce que nous avons fait, en 10 ans, nous avons réduit le taux de mortalité de 35%. Mais nous pensons que cette réduction est insuffisante pour atteindre les ODD, qui est donc de ramener donc, le taux de mortalité à 70 décès pour 100 000 naissances vivantes. Donc, notre objectif, c'est d'accélérer et de multiplier donc, la cadence par, je pourrais dire, par 3, la cadence actuelle par 3. Et nous sommes sur la bonne voie, puisque je pense qu'avec la décentralisation des blocs, avec l'augmentation de l'effectif des professionnels, surtout des spécialistes, et le redéploiement du personnel qui va à l'intérieur du pays, et y compris le renforcement des capacités des sages-femmes. Donc, je pense qu'on a, avec les audits que nous faisons, la revue donc, des décès, nous voyons qu'il y a une baisse, même au niveau des districts où on a constaté donc, des taux élevés de décès.
Merci beaucoup. J'aurai une question pour vous à la fin. Et elle a à voir avec des mesures en dehors du système de santé, parce qu'on sait qu'il y a aussi les 3 délais. Les femmes viennent trop tard. Et il y a des questions des déterminants sociaux de la santé qui empêchent les femmes d'arriver à temps, qui parfois parce qu'elles n'ont pas d'argent, parfois parce que la belle-mère ou le mari n'a pas donné l'argent. Il y a d'autres questions qu'il faut aussi travailler. Il n'y a pas que le système de santé qui a une réponse à la mortalité maternelle. Donc, je voudrais par après revenir vers vous pour savoir comment vous êtes en train de travailler sur ces aspects. Now, I would like to ask the same questions to His Excellency Mr. Selibe Mokoborohane. How hard is it? What are the challenges and what are you doing to overcome them in a short period of time? Because I have many other questions for you. Thank you.
Thanks for the correction.
moderator. First and foremost, I deem it an honor for me to be given a platform on this momentous occasion to share with you experiences and lessons from across Africa in relation to maternal mortality and morbidity challenges faced by many countries across the African continent. I wish to set the ball rolling by relating experiences and lessons from my own country, Lesotho. Lesotho is among the countries with the highest maternal mortality ratio of 566 per 100,000 live births. This is according to Lesotho Household and Population Census of 2016. This is quite an alarming situation that requires a clarion call and dedicated effort by all. However, I wouldn't say we just folded our arms and watched the space, but a number of measures were tried but yielded less than the expected outcomes. To mention but a few, Lesotho made efforts to reduce maternal mortality by implementing the campaign on accelerated reduction on maternal mortality in Africa and adaptation of the SADC reproductive maternal, neonatal, child and adolescent health strategy. Moving forward and without beating about the bush, I want to point out the challenges contributing significantly to maternal mortality and morbidity in Lesotho and the interventions that were implemented as follows. Topography of countries where women walk long distance to access maternal health services due to limited transportation for women to access health facilities. Lesotho is implementing a Imama project where community transportation is used for emergency referrals of women and newborn from the community to the health facilities. To date, with the Imama program, 4,720 maternal newborn emergencies have been referred and 90% of the referrals were women. Lack of access to quality health care. Many women in Africa face challenges in accessing timely and quality health care during pregnancy. Childbirth and the postpartum period, limited access to skilled birth attendants, emergency obstetric care and essential medications contribute to maternal deaths, as well as shortage of health workers, especially doctors. Lesotho was able to solve the challenge through prioritizing engagement of Basotho doctors for management of patients at all levels. Adequate and skilled health workforce play a major role in the reduction of maternal mortality and morbidity in member states. Hemorrhage, meaning excessive bleeding, that is postmortem hemorrhage, is a major cause of maternal mortality. According to the Lesotho Maternal Death Report of 2016 to 2020, obstetric hemorrhage contributed to 35.8% of the deaths that occurred. Limited access to blood transfusion services that are centralized and uneven distribution of emergency
obstetric care exacerbated this risk. This can be efficiently prevented if midwives are adequately capacitated. In our country, the Ministry of Health has engaged a senior obstetrician who supervises the internship program for newly graduated medical officers as a strategy to enhance capacity for emergency obstetric care. Furthermore, all pregnant women in Lesotho are given Fairfall tablets. Hypertensive disorders in pregnancy contributed 21% of the deaths in Lesotho. Without proper management, they pose a serious threat to maternal health. Therefore, an adequate and skilled health workforce that identifies women at risk and manages them is very important. Lesotho has introduced calcium for all pregnant women from first antenatal visit. Lastly, infections. Infections during pregnancy or childbirth, such as sepsis, can lead to maternal mortality. Poor hygiene practices, lack of sterile conditions, and limited access to antibiotics contributed to this problem. In 2021, Lesotho developed the quality of care guidelines to direct skilled workforce with adequate skills and knowledge to prevent and treat. Thank you, moderator.
Thank you very much, Honorable Minister, for sharing with us the challenges that Lesotho faces vis-a-vis maternal mortality. A question that's a follow-up question I would like to ask is, what does leadership has to do with this? What's the role of strong and smart leadership for us to be able to eliminate maternal mortality?
The first point of departure is the political committee, the highest office of the Prime Minister. My Prime Minister is committed to make sure that we eradicate maternal mortality. Besides, we have engaged other stakeholders to work together so that we are able to put maternal mortality under control. We have also capacitated the village health workers at the grassroots level so that the maternal mortality is managed as low as at the level of the village health workers.
Thank you. So, leadership both at the highest level and at the community level. I will come back to you with a question I would mention now so that you could tell us about it. We have days to create awareness and celebrate or educate people, our people around mostly diseases. There is an HIV day, there is a NTDs day, there is a leprosy day, there is a malaria day. You mentioned that you are implementing karma in your own country. Is there room for us to create a week or any other way of every year remembering all of us, reminding all of us that we need to do something about the jumbo jets that keep on crashing? Because that's what it is. Maternal deaths are just jumbo jets crashing every day, every week, every month around the world. And then it looks like it is okay, we are comfortable. Okay, we're doing this, we're doing that. The sense of urgency, I think it's something that we need. So I'll come back to you on ideas that you may have about that. Moving now to Ethiopia. again, I suspect the challenges will be similar. Let us know maybe something different that Ethiopia is facing as a challenge, and how are you addressing it in Ethiopia? Thank you.
Thank you, Dr. Magda. Good afternoon. Are we there? Good afternoon. Thank you so much. So, as a host country for Africa Union and Africa CDC, I would like to take this chance to welcome you to this vibrant city, Addis Ababa. Your city, of course, for all of us. Thank you very much. Give us this important chance to really discuss on our experience and the challenges that we have in terms of tackling maternal mortality and morbidity across member countries in Africa. So I'll be just brief. And yes, Dr. Magda, as you have said, the challenges are quite very similar. Just to add just few issues, I think one of the challenges that we need to address going forward, social and cultural norms and the taboos that we often see in our community, especially in remote areas, and still lack of awareness in terms of accessing services, basically family planning services and other maternal and child health services in some segments of our community need to be addressed going forward, and that is what I want to add. And especially on the issue of transportation, that needs still, especially to address the second delay, it needs concerted effort of all government, the whole of government is very important, and even it's beyond that, should be a whole of society, because the community has also its own stake on this matter, especially in terms of availing roads and also electrification for our health facilities. And basically, water for our health facilities is very important to enhance this issue. And basically, in terms of having quality health service in our health facilities, we need to have adequate medical equipment and medical supplies, and of course, human resources. And basically, for us, most of these challenges have been overcome, but we need to still progress in some of the areas. And one important issue in terms of challenge that I want to add for our case is having an accountability mechanism, having a sort of scorecard to track the performances of every sector which has a stake on this matter, and of course the scorecard of our facilities, our regional counterparts, and also the health system in general. So we have some experience on this matter. I will later mention what we have done so far. Having said this, let's share the experience of Ethiopia. Going years back, in 2000, Ethiopian maternal mortality rates stood at 950 out of 100,000. And based on the recent data that UN estimates brings to us, the data is now at 267 out of 100,000 in 2020. Even though we are passing through multiple layers of challenges in Ethiopia, we're able to decrease maternal mortality, and it is a remarkable achievement. But given the challenges and also the very ambitious targets that we have already set by 2030, which is 70, we need to do more, but we have a remarkable achievement. And this emanates from the policy, the prevention-focused policies that we are working on, and also the 5-year strategy of the Ministry of Health, and of course the different strategies that the government at high level and also Ministry of Health and the regional leadership are working on. Basically, maternal and child health services, including the nutrition service, are the top priority agenda for government at all levels. That is why we are bringing this remarkable change on the ground. And one of the success factors from Ethiopia is we are addressing maternal health services through the strong primary health care that we have already founded on the ground. So when I say primary care, basically it's all about community engagement. We have a strong community engagement at community level. So we have this platform called Health Development Army. So women, they come together, so they discuss on their issues, especially health issues, and they learn from each other, and they also support each other. And now we are even evolving this one so that the youth and other adults will also support women in addressing their challenges at their local level. So this strong community engagement that we have at ground is supporting us a lot. We are also addressing the challenges of awareness, lack of awareness, and the social taboos in terms of accessing these facilities. Another important issue is the health extension workers that we have at health post level. We have 2 to 3 health extension workers, and they are payroll-based. By the way, we have 40,000 health extension workers, and the government is paying their salary, and they go house to house to look after these services, and they also give services at health post level that service about 5,000 people, and I think that will be one excellent issue I want to raise. The other thing, Dr. Magda, you have been saying a week or a month of awareness creation for this issue. We have a Safe Motherhood initiative, and this Safe Motherhood is celebrated every year in January. So we just already finalized the Safe Motherhood just weeks back. So in this Safe Motherhood month, we create awareness for all leadership, political leadership, and also all stakeholders, including community, and we observe this at all level, not only at federal level, but also at regional, at zonal, and at community level. And that has really helped us to still make maternal and child health a priority issue. The second experience that I want to share from Ethiopia is health facility expansion and also equipping those health facilities. We have more than 400 hospitals, and we have more than 4,000 health centers in Ethiopia. As you know, Ethiopia is a big country. So, and we have 17,000 health posters, and we have been trying to equip with medical equipment and health professionals. And one issue I want to share from the side of Ethiopia is for about 500 health facilities, we have maternity waiting area. These maternity waiting areas are built in health facilities which are found far from urban areas and the city areas, and mothers who come from remote areas like 1 hour, 2 hour distance and with very bad roads will come ahead like for 2 weeks or for 3 weeks, and they will stay in those maternity waiting areas which are actually built in health centers so that they can get adequate service at that level. And the other issue I want to share is we have invested a lot in health workforce, especially having integrated emergency surgical officers that can do cesarean section. And we have 3 midwives in all health centers that can serve our mother. And of course, we have mini blood bankers in all hospitals that can serve with blood bankers. And we have 42,000 blood bankers that collect blood and distribute to these mini blood bankers. And finally, what I want to share is the investments that the government of Ethiopia did on ambulance procurement. And over the last 10 years, we have procured more than 4,000 ambulances, and they have been distributed to all districts. You know, we have 1,000 districts in Ethiopia, and each district have 3 or 4 ambulances, and we are also working on road expansion, and I think these have supported us a lot. And finally, on the issue of monitoring and accountability mechanism, we have MPDSR, maternal and perinatal days, surveillance and response, and this is bringing on board all stakeholders, especially the leadership at district level, to be accounted for every maternal days. So they will audit at facility level and also at community level every days of mother, and then they will act upon that one so that we shouldn't see another similar maternal days at that level. So I would like to thank our partners for the heavy presence and support over the last, especially 2 decades, and of course, the commitment of the government and the engagement of our community in this successful journey. Thank you.
Thank you, Honorable State Minister for Ethiopia, for those accounts on how Ethiopia is tackling maternal mortality and the huge reduction that actually has taken place. And from what you have said, I think it's strengthening the whole system across the board has contributed immensely to reducing maternal mortality. You talked about the role of society involvement for reducing maternal mortality. You talked about women supporting each other. I wanted to hear men supporting women so that we could also reduce maternal. Male involvement is important. There is no way we could reduce maternal mortality without that. I'll come back to that as your second question. And I want to hear what civil society is doing as part of the whole of society involvement, because it cannot be just government and partners and community. We also need to see what we get from the other partners of governments, particularly civil society. We see how civil society is vocal around HIV, around TB, around malaria, maternal mortality, what is happening in the countries with civil society. I'm now going to invite, Professor Dr. Patrick Kadama from the Africa Platform on Human Resources for Health to come and tell us how can we go about the major challenge that we have in providing skilled health workforce for maternal health. Dr. Patrick Kadama, please. Thank you.
I thank you very much. Excellencies, distinguished participants, and all protocol observed. First, I wish to thank CDC for giving us the opportunity to be here today to continue our participation in this platform, which we have been involved with before and after it was formally launched. We are very proud to be able to continue this contribution. Second, I must congratulate all of you for the great reduction we have seen, much as we are still very far away from targets. We have seen what I would call substantial reduction in maternal morbidity and mortality. For this, I think we must all commit to this continued improvement and to redouble our effort to move towards our goals. The experiences that the ministers, the honorable ministers, have just gone through really outline the problems. But distilling out the critical elements for the purpose of building a health workforce to respond to it requires us to probe down further. There are two critical elements that are required to address or to tackle maternal morbidity and mortality. They are to do with anticipating, and you could hear from all experiences, anticipating what might happen, what will be the crisis, and to how will delivery take place. The first action, which is elemental and critical, is called antenatal care. This assesses the pregnant woman for possible complications so that you anticipate better. Those of you who are studying surgery, you remember this. A good assistant is one who anticipates the next action, because the surgeon will put his hand here, you must put the correct instrument there. Don't put the wrong one. You'll be out of theater. So we must also act like that with maternal mortality. We must, morbidity and mortality, we must anticipate these well in advance. The second element that we must anticipate is what will happen during delivery of the pregnant woman. Now we must have the skills to conduct antenatal care. We must have the skills to conduct delivery, skilled assistance at the time of delivery. The bad news, despite all the progress that we are having, the numbers which I'll express in terms of densities rather than nominal figures that we sometimes hear of the multitudes of people that we have trained, the density of health workforce required to manage pregnant women has remained almost stagnant in this region. This, at present, if you look deep enough, is almost 16 times less than what would be expected if you use the global figures that we have been using over the last 10 years since the joint initiative study. And those figures were also not good, but the figures specifically to to conduct antenatal care and to conduct assistance for pregnant women are very, very low in this region. And therefore, we must begin to have better data to track where we are with this. The second thing which is becoming more probably prominent since we started looking at these analysis is the emerging evidence that even the small number of the small density of care that we have is not being used optimally. We are not optimizing access to the few health work density that we have. So we have a problem which I think has been better expressed in the previous sessions, but have been touched upon here. What are the other health-related services that support utilization? They are usually to do with traditions and culture of health-seeking behavior. This compounded by the stickiness in raising densities, which we call demand in economic terms, not in terms of need. Demand as separate from need means that we are unable to purchase the technical skills to conduct these two activities. We may have many trained people, but in the system, there is evidence that many people are going to be trained in developing countries for health workforce, but many of them will be taken out by other countries in middle and upper income who have a demand, meaning that they have the money to purchase skills. Ours, if health workforce was a commodity in the supermarket, it is a commodity that we are not buying. It's a commodity that has very low demand in developing countries. Your leadership is required, Excellencies and honorable ministers, to ensure that we generate demand. How can we address resource allocation to go over this? Your leadership is also required, on the other hand, that we work with others across sectors, that we work with others with other skills beyond the traditional health workers to influence health-seeking behavior. There is also some evidence coming up that much of the progress we have made has been through the influence on society in developing countries, changing lifestyles to access more effective care modalities. It's not because we have built a lot of them and we have a lot of healthcare workers, because the densities, when you look at the densities, we are not catching up with the population expansions. We are not coping up with the demand. We are not picking up the demand. There are many things which are being done, but I think they have gone through, fortunately, they have explored most of these. How can we, I was told to say something about how the strategies that we can use to address these factors. I'll refer to my notes, but we have heard something about investing in education, infrastructure, the three elements of capacity development, usually plant and equipment, capital, and human resource development. Reforms of curriculum are lagging behind. We are still too technically focused. We are not looking beyond We are not looking beyond to engage the others who work in other sectors in order to have health workers that engage on culture, on traditions, to influence health-seeking behavior so that when we have our service, they are able to take it up. The issue of incentives, I think, is easier to talk about. Targeting underserved areas, leveraging technologies, artificial intelligence is coming up, but improving health information systems, data collection, improvement in interpretation, so that decisions on how to generate demand and how to influence health-seeking behavior is based on data that has been collected and is put to use. We have regular reviews which require to be probably promoted much more than we are doing today. I'm glad that this platform has taken shape where we can regularly meet, share experiences, learn from one another, and mainstream those lessons without additional cost. The capacity development in information systems, I think, is something that I need not say much more. But the bottom line is that, one, I think we have got to learn to work with others in other sectors. They have enabled us at very little effort of improving density of health workforce to have a progress in reducing maternal morbidity and mortality. If we want to move on the health workforce agenda, it will have to be a reform on how we work with others, not to increase the numbers not necessarily to increase the numbers in the sector, but to increase the collaboration between the sectors as we move together to increase, because the pressure for more workers is across sectors, both as welfare workers, community workers, and health workers. We shall have to increase these all together. I thank you very much.
Thank you very much, Dr. Patrick Kadama, for reminding us of the need of collaborating across sectors and doing better with what we have. For sure, we need to increase numbers, but doing better with what we have is a good recipe for success. We are close to our lunch time that Dr. Alice said it was going to be at 2 o'clock. The questions I have given you homework for, I'm going to give you 1 minute, each one of you, for those questions. So on social determinants of health, we didn't really touch on issues of access to sexual and reproductive services. We didn't touch upon teenage pregnancy. We know it's also responsible for maternal mortality, early marriages, etc. But just quickly from you, Honorable Minister, what is Côte d'Ivoire doing in terms of addressing social determinants of health that has an impact on maternal mortality? Thank you.
Merci. Vous avez effectivement raison. Donc, je pense que au niveau donc des facteurs qui favorisent aussi, qui influencent donc la mortalité maternelle, il y a des facteurs sociaux, notamment donc les pratiques culturelles qui dans certaines régions où des matrones ou des populations donc attendent de réaliser un certain nombre d'actes avant donc de transférer par exemple les personnes qui doivent accoucher donc à l'hôpital avec des retards. Et donc dans ce cadre-là, ce que nous faisons, c'est que nous travaillons avec ces personnes. Nous les impliquons dans le système. Je sais que dans la zone nord où ces pratiques sont courantes, nous avons intégrer ces femmes-là donc, dans le développement donc, de la santé communautaire, et elles participent comme des aides-soignantes aux côtés des sages-femmes pour prendre en charge ces femmes et surtout faire la promotion donc, de la santé maternelle. Donc ça a permis d'améliorer donc, nos indicateurs à ce niveau. Mais surtout, ce que nous faisons, c'est surtout la responsabilisation de la communauté vis-à-vis donc, de toutes les mesures prises et toute la stratégie mise en place. Je l'ai dit tantôt, l'État du Côte d'Ivoire, avec ses partenaires, ont rendu gratuit un certain nombre de soins, notamment donc, les consultations prénatales, pour vraiment préparer la femme à aller donc, sereinement donc, à l'accouchement. Et les 4 CPN doivent être observés avec une relevabilité qui est au niveau de la communauté, sous la supervision donc, des infirmiers, des sages-femmes qui sont dans ces localités-là. Donc il y a des rapports qui sont faits régulièrement et avec donc, nos directeurs des districts, nous passons donc en revue ces choses et nous travaillons donc à renforcer la capacité des communautés donc, à prendre en charge les grossesses. Il y a également donc, ce que nous avons constaté également que beaucoup de femmes, pour des questions donc, de moyens, peuvent attendre. Mais c'est pour cela qu'à chaque fois qu'on a vu des barrières ou des blocages qui peuvent donc être à l'origine des décès, le gouvernement a essayé donc de faire face. Dernièrement, la mesure urgente que nous avons prise, c'est donc de faire en sorte que le transfert en urgence des femmes ou des personnes malades donc vers les centres de santé puisse être fait de façon gratuite avec le renforcement du parc des ambulances que nous avons pu faire. Et donc cette mesure facilite aussi l'accès donc, des populations donc, vers les centres de santé pour leur prise en charge rapide. Sans compter que, bon, comme je l'ai rappelé, les kits d'accouchement et les césariennes étant gratuits, et nous veillons à ce que ce soit effectif parce que quelquefois les mesures sont prises, mais dans les coins reculés, donc ça n'est pas le cas. Et nous veillons à ce que ces mesures-là soient vraiment effectives dans toutes les localités. Et les zones qui sont d'accès difficile, je l'avais dit, que ce soit pour le sang ou ces kits, nous avons donc innové avec les drones qui peuvent transporter donc, en urgence donc, ces équipements-là pour que ces femmes-là puissent être prises en charge.
Merci beaucoup. Going now to Lesotho, Ethiopia told us that January is Safe Motherhood Month, the whole of January in Ethiopia. We also heard from Dr. Patrick Kadama that we need to increase demand from the women for quality services. They need to come more. How do you increase awareness about the dangers of pregnancy, the potential dangers of pregnancy, or encourage safe motherhood in Lesotho outside the health sector, beyond the health sector?
Well, in our calendar, we do not have a week or specific days where we are maybe commemorating maternal mortality. But I think this is an opportune time. It is a wake-up call to us, not to wait for WHO to tell us that so and so days or weeks should be commemorated as a maternal mortality week. As I get home, upon arrival, I'm going to ensure that in my schedule, we have a week where we will have to sensitize the nation about maternal mortality.
I think it deserves a round of applause for the measure, very clear measure he's going to take as soon as he gets back home. It is important really to go beyond the health services and sensitize women, teenage, adolescents about, and men about the risks and what they can do to contribute to reduce maternal mortality. Don't forget to involve men. I want to know what civil society is helping with in Ethiopia.
Thank you very much. One thing that I missed is the health barrier. That was one of the serious challenges that happened in Ethiopia, and I think the other countries may also have this experience. We have made now, especially over the last 15 years, maternal services are provided completely for free in public facilities. So there is no any payment for that one, and I think that will break the financial challenges, and it will also take us forward in terms of achieving financial risk protection to achieve UHC. So that could be one experience. For main involvement and the CSO involvement, previously the main involvement was a bit lesser. We didn't recognize the benefits, and hugely the Human Development Army based on women. So recently we have included that one, and especially in remote areas, the youth and the men, they will have these traditional ambulances where the infrastructure is a bit challenging. So they will take through those traditional ambulances to where ambulances can access or to the nearest health facilities. And also the first antenatal care visit should be accompanied by the husband. So that's also part of our implementation guidelines. So they will go together to have the tests, including HIV tests. And of course, if there is home delivery in any home, the adults or the youth will be requested why that specific mother have delivered at home. So they will be also responsible for that one. So now they are part of the movement, and we are also seeing the benefit. For the CSOs, previously, the CSO space in Ethiopia was very challenging, and their contribution, especially in maternal health, was a bit less. But now with a serious reforms that our Prime Minister, Dr. Abiy, is undertaking, now there is a very big political space and operational space for our CSOs. They are engaging a lot, especially over the last 5 years, in terms of advocacy. For example, these safe motherhood months have been driven by these CSOs. And of course, they have now many projects working on maternal health, and they go to community level, they advocate, they also provide medical equipment, supplies, and also when those mothers go to facility to deliver, they will take over of their kids and their household. So their involvement and engagement is progressively increasing, and we have seen also the response on that one. Thank you.
Thank you very much for sharing those experiences. Indeed, civil society tend to be seen as just the one intervening in politics and political issues, but this is an important political issue for civil society to be engaged and given the space to help with advocacy, awareness creation, and sometimes even providing services where government is not able to. Dr. Kadama, I believe you have given us what needs to be taken into consideration when it comes to human resources for health. I don't know whether you have one last message that you would like to leave for the ministers. Alpha minutes, and while he does that, I would like to invite the Minister of Health from Somalia to join the stage for a short message before we go for lunch, please. Thank you. Yes, Dr. Kadama.
I'd only like to thank you once again and to stress leadership of our political heads and excellencies in generating demand, 2, in ensuring collaboration to change health-seeking behavior towards more effective technologies of care. Many of us are still dancing under the tree, hoping to have good returns, and only going when we start bleeding. That's too late. We need to be changing this, and the effort is with our leadership to ensure this broad collaboration on the demand side to change behavior, on the supply side to generate demand.
Thank you. Thank you very much. I would like to really thank the panelists for this session on maternal mortality. I think a lot of leadership, a lot of drive is going to be needed from you in your respective countries, but also the examples you have shared with the room will definitely, I hope, be helpful for other countries as well. Thank you very much for spending this last hour with us. Thank you so much. Yes, please, Honorable Minister. A round of applause for the panelists. Thank you. Yes, you have the floor.
Distinguished Health Ministers, esteemed representatives, and esteemed guests, I extend a warm welcome to all of you to this significant Africa CDC ministerial meeting. Today, we are not merely convening for the Ministerial Executive Leadership Program. Our purpose is to shape the future of health resiliency and progress across our continent. Our shared objective is to strengthen healthcare systems. Let us collaborate to establish partnerships, exchange best practices, and pave the way for healthier and more resilient health Africa. Over the past 3 decades, Somalia has faced persistent armed conflicts and natural disasters that have had devastating consequences for the overall health sector. This has particularly impacted the health workforce and service delivery. The healthcare infrastructure remains fragile, impeding access to essential healthcare services, especially in rural and conflict-affected areas. A critical issue lies in the lack of infrastructure, with many facilities lacking essential resources and adequate healthcare workforce. Fragmentation exacerbates the problem as various public, private, and NGOs entities provide healthcare services without efficient and sustainable coordination. This leads to inefficiencies and gaps in service delivery, compounded by a shortage of trained health workers. Furthermore, due to insecurity, conflicts, and limited opportunities, many professionals have left the country, resulting in shortage of trained health workers, including doctors, nurses, and midwives. The emergency of the coronavirus has exposed the fragility of our country's health system. Through NIH Somalia and our partners, we have enhanced the diagnostic capacity of our public health reference laboratory and cross-border surveillance. More needs to be done to strengthen collaborations among Africa's public health institutes to facilitate mutual support. I wanted also to take this opportunity to inform Honorable Ministers of Health that Federal Government of Somalia proposed to the Executive Board of the World Health Organization resolution to accelerate the reduction of maternal and child mortality in line with the targets set in the United Nations Sustainable Development Goals 3.1 and 3.2. The objective of the resolution is to mobilize intensified technical and financial support for the countries that will not achieve Sustainable Development Goals targets to reduce maternal and child mortality, including Somalia, to address the direct causes of maternal and child mortality, but also health systems bottlenecks. To this end, the Minister of Health and Human Services led and coordinated consultation process with the member states of the World Health Organization to get their input and support. We are blessed that the resolution proposed by the federal government of Somalia has gained support, was co-sponsored by Egypt, Ethiopia, Lebanon, Paraguay, South Africa, and Tanzania. We want to thank these countries that co-sponsored the resolution, and we welcome additional co-sponsors from the member states. The Minister of Health of Somalia will take this forward to finalize the resolution, which will be submitted to the 77th session of the World Health Assembly in May 2024 for adoption. I hope that all the ministers of health here will endorse and will support that resolution. Thank you very much.
Thank you very much, Honorable Minister from Somalia.
Thank you. We are going to break for lunch, but I was reminded that a number of ministers came in and delegates came in after the photo session. So we're going to have one more photo session just in front here. So please, delegates, speakers, honorable ministers, kindly come to the front here, and the crew that take photographs, please, let's do this in 2 or 3 minutes, just here, just in front. Thank you very much. Can senior Africa CDC leadership please join in the photo? We will need a few people in the front so that we are not too broad. Yes. No chairs. So some can come and stand at the top. I realize to get this. Not, you don't need, yes, but yes, I did, of course. Faith. Excellent. So here is the guidance for lunch. This is a networking lunch. So when you go to lunch, ministers, your delegations, speakers, and senior Africa CDC, please go to the indoor dining section. And the rest of us will go to the right. And no, the speakers, delegates, please go to the left as you are going to lunch. You can, there's a, ministers are not going that way? Yeah, okay, please go that way. There are ushers to lead you to where you are going. But let the ministers lead the way, please, through this entrance on the right.